is Anele Yawa. I am the General Secretary of Treatment Action Campaign and the Chief Accounting Officer of the Ritshidze project. And I am not alone, I am with my comrades. I will start from my right-hand side. Can you introduce yourself, my leader?
Good morning, comrades. My name is James Oladipo. I am the senior researcher on the Ritshidze KP project. Thank you.
Good morning, comrades. My name is Mpiwe Klava and I'm the Ritshidze project officer. Thank you.
Good morning, my leaders. This is Kagiso Mohotlwane. It's the Tshwane district organizer, Ritshidze. Thank you.
Thank you. We are going to start the meeting. I know today is hot and even this tent is affecting us. And I will ask that when we give testimonials, we do not take long so that we can finish early. But also in order for us to speed up a program, I think it will be good if we can put our phones on silent. And I'm sure we were advised that whilst the session is on, can we please not use our phones because we will be disturbing the team which is recording. But if we want to view the whole session, you can go to YouTube, you will see the whole session. Also, in the room, we've got officials from the Department of Health and other people, but I've got an eyesight problem. I will ask Comrade Simpiwe to read all of them. Hoye.
We have got Ma'am Margaret Ngobeni, Tshwane Clinical Health Coordinator. And then we have Dr. Nombuso, Clinical Health. Oh, Ma'am Margaret Ngobeni. Thank you. For our Clinical Health Manager at Province, Dr. Nombuso. We have DOH officials, Chief Community Liaison Officers, Mutlalipula Murena, sorry. Masha Ditsejo. We've got Area Manager from SAP 1, Elizabeth Zita. From PHC Management, we have Mr. Mudise Makubu. Also from PHC, Stina Mujela. Cluster Manager from VETS RHI, Palisa Masimula. PM, VETS RHI, Nosipho Juili. Where's that other one? We've got Deputy Director, Art, Kensani Chauke. Drug-resistant TB, Tembangwenya. Thank you.
Thank you, Comrade Simpiwe. But also, if there is any other official who is here in the room and was not introduced, please let us know so that we can acknowledge you. Nangu ma'am. Usazi introduce ngokwakho ke ma'am.
Good morning, all who are in the tent. My name is Tsolofe Longkhodi. I'm the acting deputy director for HAS program in Tshwane. Thank you.
Thank you, Mama. And also, Sizawuzakuwe, Mama. Sizawuzakuwe, Mama.
Tumela. OIM Mopele Khalena, ke Maria Kobo, PHC Manager, City of Tshwane.
Thank you, Mama. But also the MEC of Health has submitted an apology. She was supposed to join us online. Unfortunately, she is unable, including the HOD. Mr. Mahoro, the COO, was supposed to be here, but something urgent happened, and Mr. Mahoro has requested to join online. The HOD and the MEC, if they finish early, they might join us online. So, ndiyathetha ke mna ke ngxaki. Siyathetha? Ah, makuthethwe. Riyabu? Zonke. Okay. Siyabonga. So, today we are having this meeting. This is our mix like Konglish. Yeah. Today we are having this meeting, which is a community meeting with the officials from the Department of Health, as well as the political principal, which is the MEC. This meeting today we are going to present a report on the state of health in Tshwane, which was conducted by Ritshidze. We are not a research institution. We are a community-based organization that is fighting for the rights of people living with HIV, cancer, sex workers, people who are using drugs, men having sex with men, gays, lesbians, and everyone who is a citizen of the country. We are monitoring the state of HIV and TB services in the health facilities that are monitored by PEPFAR in South Africa and here in Tshwane. We have been engaging with community members and the users of the healthcare services to try to understand, as to say, are we all satisfied with the quality of the services that we are getting from the public health sector? Can we please not disturb each other, guys? Because if we talk while others are talking, it's going to be something that I do not know, chaos. So, the work that we are doing, we are working in clinics, working with community, as means to ensure ukuthi people living with HIV, TB, and all other illnesses, when they go to our health establishments or clinics, they access quality services as enshrined in the Constitution. Section 27 of the Constitution talks about our right or rights as citizens to access quality healthcare services, and it goes on and on and on and on. And as Ritshidze, we started this work around 2018, focusing in these facilities. We are working in 8 provinces, in more than 400 clinics in the country. And this is a 3rd report that we are releasing today. But this time around, we realized to say, we are not going to invite Abo MEC alone. We want to go down to where service delivery is implemented at facility and at district level, to create a platform between the community and the officials, in order for the officials to understand the plight of the public healthcare users, what we're going through, in order for that to assist in facilitating a process to fix the problems that we're experiencing on the ground. Majority of the people in this room and in our communities are subjected to wake up as early as 4 a.m. to queue in our clinics. And then the clinics will start working from 8. Wait there, outside, on this heat. We are better because we've got a shelter. Majority of the people in our clinics do not have shelter. Whether it is raining or hot or whatever, they are forced to sit there and be attended around 10 o'clock, and only to be told 1 o'clock that, no, go home, we do not have your medicine. Or you miss your appointment, today, because it was raining and you realize that your clinic is very small, you cannot expose yourself into the rain and be wet, and you decide not to go on that day, you go the following day. When you go the following day, you are told at the clinic, irrespective of the time that you arrived, that you will go right at the back of the queue because your appointment was yesterday. And in some instances, people are turned away in our clinics without getting the services they need. In some instances, when you are living with HIV and you do not want your status to be known, UNES will get out of that room and say, all those who came for HIV treatment this side. And then the community end up seeing you, oh, and then people end up disengaging. You go to a clinic as a young person who was raped, and then in that process of being raped, you ended up falling pregnant, and you do not want this child. You want to terminate the pregnancy. You go to a clinic, a nurse starts preaching at you to say, this is abortion, and if you are doing this, you will not go to heaven. For God's sake, we didn't go to the facility to be lectured or for someone to preach, but we went there for services. You go to a clinic, you are a gay, you are a lesbian, you are a sex worker. A nurse is attending you in a private room, and then you tell a nurse about everything, and then a nurse walks out and calls another one to come and hear this. And then you are being made a mockery. And other issues that we as the public healthcare users are confronted with. These small, according to what others might see, small problems is what end up being a big crisis for the country, which makes majority of the people to decide not to go to our clinics and disengage or benze what is called silent transfer. I was ill-treated in this clinic, I will transfer myself without telling them and go to another clinic. And then here they say, I is lost to follow up. In South Africa, we've got a problem, colleagues, of not being able to reach the second and the third 95. Retention to care and adherence. People living with HIV, because of the treatment that they are exposed to in our clinics, decide not to go to clinics. They select to die in silence with their dignity intact than going to some of these health establishments and be ridiculed. And when they walk out of those clinics, they don't feel as human beings anymore. Yet we've got a country that has a constitution which gives us a guarantee to our rights to access healthcare services. We've got a country that has what is called a Bill of Rights, where you are told about a freedom of association and freedom of choice. But when, because of the material conditions, socio-economic conditions, you decide to be a sex worker, you are made to feel as if you have committed a crime in a country that is not employing young people who are educated. In a country where employment opportunities only have a face and a name. And if you do not look like that and you do not have that name, you won't be employed. And then we are suffering. People end up opting to other ways of making money. So that's why we are having this meeting today. Because in South Africa, we've got an estimated number of about 8 million people living with HIV. Close to 5 million plus people living with HIV are on antiretroviral treatment. And 2 million plus people living with HIV are not yet initiated on treatment. But even those who are on treatment as we are talking, they are experiencing a lot of challenges, which makes them to disengage. Majority, we've got 100 facilities in the country that are not doing well. And then in June and July to August, we did our own fact-finding mission by going on the ground. And then we had a meeting in August with the department to say, Dr. Mowerane and your team, actually, UNAIDS, PEPFAR, it's not 100 facilities. It's more than that. Majority of our clinics have a problem of the high defaulter rate. This high defaulter rate is caused by the ills that still exist within the system. We've got a welcome back program. We have all these programs. But what sense does it make for the community to encourage Anele to go back to treatment if Anele is going to go back to the same clinic and experience the same problems that made him to disengaged? So we are saying now, as TAC and Ritshidze, PLHIV sector and communities, we are able to fix our problems. But is the department willing to address the problems that we're experiencing on daily basis in our clinics? Because if those problems are not addressed, people will walk in through the front door and walk out through the back door and never come back again. Within the system, we've got few nurses who are spoiling the good work and good efforts of committed nurses. It is these few nurses who keeps on insulting the community, who keeps on violating our rights, who keeps on disclosing us, who keeps on shouting at us, who keeps on thinking that they own government institution. That's what makes majority of the people not to go to clinics and decide to die in silence. And from where we are standing, we know that there are multitudes of good nurses. But if we can name and shame the ones that are ill-treating the community, we might be taking few steps towards the right direction. So we are here today. We've got a report that is written. We've got recorded videos of people giving testimony about their experiences in our clinics. Even in the room, we've got people who've got a story to tell. Because in our clinics, we do have suggestion box and complaint box, but those things do not work for us. You write a complaint, you put it there. You walk out, they open it there. Babuze, who is Anel? Hi, that one on Fuchano and Cheb. The next time when I come back again, you get attitude from the nurses because you wrote a complaint on the box. Majority of facilities have facility managers who are living in fear, because I'm a facility manager in this clinic and the majority of the staff that I am managing do not belong to my union. Should I reprimand them, they will organize and mobilize and toy against me as a facility manager. So I decide to fail the people that I am supposed to serve, because my interest is to nurse our working relations within the department or within the clinic on the expense of the majority of the people. When complaints are brought forward, I'm scared as a facility manager to challenge the culprits because I know they will toy. South Africa is moving towards the implementation of the National Health Insurance, which gives guarantee to the people of South Africa, people of the world. It gives them a guarantee, a right to access quality healthcare services without being judged according to gender, race, affordability, and all what have you. And the majority of the people wants the NHI, but if we're still having these problems, it therefore means our NHI will never be a success. In South Africa, we've got a population of about 62 million. And 42 million of those people are public healthcare users. And about 14 million are using private. And the other 5 million, nobody knows where they access healthcare services. But when you look at the population that we have of about 42 million public healthcare users, and you begin to compare it with the healthcare workforce, with both in private and public, we've got less than 500,000 health professionals who are expected to provide quality services to 42 million. We've got a problem of shortage of nurses, doctors, pharmacists. We've got a problem of our clinics that are old, falling apart, very small, no enough space, no privacy, where when you are consulting a nurse, in the same room someone is being consulted, and there is no privacy and confidentiality, which makes other people not to feel comfortable. I cannot go to a clinic where I share the same room with another patient and I listen to the patient's illness, and that patient is listening to my illness. Where is human dignity? Where is privacy? Where is confidentiality? As I am going to hand over, not long ago, Minister Enoch Gauteng, Minister of Finance, during the midterm budget speech, they told us that they are going to take about 1 billion from the health budget, more especially on HIV and TB services. They are going to invest it some. What does that mean? It means the same problem we experienced during COVID or during a lockdown, we're going to experience it again. Where HIV and TB services were no longer a priority, but a priority was a COVID. Where gates of our clinics were locked, we were subjected to give our files over a fence to a security. A security who is not a healthcare worker was privy to know, because files are given to the security. The security was privy to know illnesses of community members and the treatment they take. And then after child time, the security go home and say, treatment HIV. And then his partner will tell this other one, the other one will tell the other one. The community ends up knowing Ukuti, this one is taking a treatment. So we are having a lot of problems, but today we're going to be focusing on issues that are around Tshwane. And then in that process, we will allow community members to say things the way they are. And some of us, maybe sizavukela imimoya. Uvukela imimoya does not mean that we are fighting. The reason we are having this engagement with Abo MEC, OHOD, and everyone, we want all of us to work together as a team to address the problems of the community, so that when someone wakes up at home and go to a clinic, you go to a clinic with a smile and you come back out of that gate with a smile again, instead of going there with a smile and then when you walk out, you are frustrated. So without making State of the Nation address, our report is going to focus on the following issues: staffing and waiting times. Yeah, the problem get to say meeting in about abazinkokheli when you are all leaders, yabo. It's like I told I am a leader now. Sacela maqabane sizibeke silence phones zethu. Andithethi nawe but ngicela indlu yonke. Siqala ngendaba ye-staffing and waiting times, ART collection, ART continuity, key populations. Siyayijamba issue of index testing. And then we talk about infrastructure and clinic conditions, TB, infection control. And then after that, we're going to give 2 minutes to a leader from NAPO, 2 minutes from a leader from TAC. Then after that, we're going to give to one person 5 minutes from EVETS, and then we're going to give to Department of Health. But I do not know how is the arrangement, because I can see there is district and there is a province. But the department knows the protocol, and then after that, we will close the meeting. So we will start with item number 1, which talks about issues of staffing and waiting times. Over to you, James.
Thank you, GS. This week, we launched the 4th edition of the State of Health report for Gauteng, developed using data from Ritshidze's community-led monitoring. Ritshidze monitoring takes place on a quarterly basis in 128 facilities across the province. This week, we are holding 3 district community meetings, yesterday in Ekurhuleni, today in the City of Tshwane, and tomorrow in Johannesburg. We will be deep diving into both the progress and challenges across the 3 districts, and hear directly from people living with HIV, people who use drugs, sex workers, LGBTQIA plus community members, and other public healthcare users as the real experiences using clinics in each district. Today, we are in the City of Tshwane, where we monitor 29 facilities. Data are collected through observations as well as interviews with healthcare users, which includes the public healthcare users, people living with HIV and key population, as well as healthcare providers, which includes facility managers and pharmacists. Data in this report was collected between July and August 2023. Interviews took place with 29 facility managers. Observations took place at 29 facilities. Interviews took place with 1,516 public healthcare users, where 50% identified as people living with HIV and 6% identified as young people under the age of 25. First group of issues are on staffing and waiting times. Improving the state of healthcare services provided at our clinics so that all people living with HIV and key population can access friendly, welcoming, and quality services depends mainly on having enough qualified and committed staff in place. This year, only 45% of public healthcare users interviewed reported that there are always enough staff at the facility. This has improved from last year, where just 33% of people said there were always enough staff. The best performing sites are outlined in the table shown, and the worst performing sites are outlined here, with some sites scoring particularly low. From the perspective of facility staff, only 8% of facility monitored reported that there were enough clinical and non-clinical staff to meet demand, having dropped substantially from 38% last year. There is a long way to go to fill the human resource gap, as 92% of facility monitored remain with too few staff to meet demand. Of facilities reporting shortages, 27% of facility managers blame there not being enough open position on staff shortages, while 32% blame staff shortages on one or more unfilled vacancies. According to facility managers, the most commonly understaffed cadres were professional nurses, cleaners, and data capturers. There were 124 vacancies reported in this reporting period. The highest number of vacancies by cadre are by far professional nurses. 78% of facility managers we spoke to specifically wanted additional human resources for health support from the PEPFAR district support partner, VITS RHI. However, PEPFAR's funding for critical HR posts has only reduced in recent years. Average waiting times have reduced over an hour in the last year in facilities monitor in the City of Tshwane, down from 4 hours, 37 minutes to an average of 3 hours, 39 minutes waiting in the facility, and this includes the time before the facility opens. And waiting times after the facility opens has reduced from 4 hours, 20 minutes last year to an average of 3 hours, 19 minutes waiting after the facility opens. However, 24 facilities still had waiting time over 3 hours as outlined in the table, with some waiting hours over 4 hours. This means that some public healthcare users still spend hours in the facility, and this is a major source of dissatisfaction for those who experience the long waits. 64% of public healthcare users interviewed in the district think the waiting times at the facility are long. This has improved slightly since last year, where 74% of public healthcare users thought the waiting times were long. 42% of public healthcare users blamed long waiting times on staff shortages, and 33% blamed staff not working or working slowly. While 93% of public healthcare users were aware of clinic appointment system, only 33% report getting both a date and a time, and 63% reports just getting a date. This means people arrive early in a cluster in order to get seen, and the clinics are empty by the afternoon. Appointments could be spaced out throughout the day to ease congestion. Filing systems were observed to be in a good condition in only 41% of sites monitored, down from 48% last year, mostly due to filing rooms being too small to maintain or filing systems being messy. 50% of public healthcare users blamed long waiting time on messy and disorganized filing system. Messy and disorganized filing system increased delays and increased the burden on already overstretched healthcare workers. The average earliest arrival time has improved slightly, from 5:14 a.m. last year to 5:22 a.m. this year, and some people still begin queuing early in the morning in an attempt to get seen more quickly. 26 facilities monitors still have an average arrival time of before 6 a.m. Of 775 people who would arrive before the facility opened, 30% reported feeling unsafe or very unsafe while waiting for the facility to be opened. While a circular was issued in May 2019 by the National Department of Health, calling on facilities to open by 5 a.m. on weekdays, none of those facilities monitored even opened before 7 a.m. Commonly, facility managers tell us that they are unable to extend opening hours due to insufficient staffing to cover this time. Yet, only 53% of public healthcare users think the facilities are open for long enough, and 64% think that extended hours would improve access to services. Now we move to recorded stories.
Ndingumphoshiya Zenzile, ndihamba ikliniki Phomolong ndithatha i-treatment for HIV. Then i-problem yam i-one nje ukuthi sifika ekuseni, sometimes it's 5 o'clock, singene ngaphakathi by 7:30. Iyakhawatha, sometimes kuyabanda, sometimes kuyanetha. Sometimes i-delay iba khona, like ixesha labo liba slowly. Mhlambi siye sifumane o-sister abayi-2, inumber yethu ibe over, and then no sister kuba khona ixesha labo le-lunch. So sometimes iyavakalela xesha, iyavakala laa nto yokuthi ii-sisters ziyashota.
Mna ndikhalazela i-service engekho eslow. Sivuke ekuseni sihambe late, ndithatha i-treatment ye-HIV ne-high blood khona la ePhumlweni Hospital clinic. Siza ngabo 6, ndize ngabo 6, mara uthola ukuthi uzawuhamba ngo 4 since ubuze eclinic. Asazi nokushota istaff na or ukushota ntoni ngoba sibona nje ba asikwazi uba basisevise ngesikhathi. Mna bebendiphethe 2 months. Kaningi bendingazi la eclinic bendithatha la sizithatha khona kuma-Shoprite ize 2 months. Hayi basichazela nje, andithi azifundanga ngesikhathi. So awuke umuphanda into yokuthi i-results njani, bona bayabhala ngaleso sikhathi zifikile, bayabhale bakuphe ipilisi.
Eclinic engihamba kuyo, ngihamba eSoshanguve Block TT clinic. Sinama challenges esihlangabezana nawo uma siya emakliniki noma ezibhedlela. Then ama challenges esihlangabezana nawo ukuthi nje mawuye eclinic, into yokuqala uma ufika mhlambe uhamba wedwa, awubi nemashali ezokuhambisa uze uyofika mhlambe ngaphakathi eclinic. Then uthi mawuso ufikile futhi uhluphekele ukuthola ifile. Uyahlupheka ukuthi uthole ifile. Uhlala isikhathi eside, more than i-hour, ulinde ukuthi mhlambe balinde bakhiphe ifile yakho. Sho ukuthi uma ngabe mina ngifika eclinic ngo7 wasekuseni mabavula, mina ngiyoze ngihambe ngo2 wantambama, ngoba abas-attending ngesikhathi vele sifanele. Bathi mabafika nje bafike bayadla, mabafika bayadla phuza itiye, bakhulume bakukhulumayo. Ngisho noma sebakufakile ku-consult room, sho ukuthi uyangena, abaqali bak-attend, baqale nje bakhulume nje indaba zabo nje mhlambe ezingasimayelana nalokho wena okuzele nje, yabo. Bahamba isikhathi eside, umuntu ukwazi ukuhamba i-hour lonke athi ayo-check ifile. athi makabuye vele abuye mhlambe athi lahlekile. Kuyadingeka ukuthi njalo mhlambe mangabe kukhona lapho sidinga uku-applyela khona baye basipha ama-form ekumele agcwaliswe udoctor. So udoctor makangena medical report ukuthola kunzima ukuthi afakaze ngakho lokho kuyobe kudingeka ukuthi afakaze ngakho lapha ku-form. So sikuthola kunzima ukuthi sihambe eclinic sisizakele. And ifile ilahleka kanjani ngaphakathi bathini e-filing room ngoba kulaba agcina khona. So mina nginaleyo nkinga ke.
We move to community members that have joined us in here.
Okay, nna ke attenda clinic Mamelodi stanza 2. Challenge ya ka ibile hore e be ke lo consulta ka PrEP. So
I attend the clinic in Mamelodi called Stanza 2 Clinic, and I went there for PrEP.
so challenge e ke bile le yona ba mfile attitude a sa nka ba nya go theetsa reason e be ke nyaka go tšea PrEP. So ba no insulta ba ba rude towards me. So ka enta pa ile hore ke a jika.
So I did not get the assistant. They did not even want to listen to the reasons why I wanted to be initiated on PrEP. They were just rude and they insulted me. I end up leaving the facility without getting PrEP. My challenge is
the clinic ya Stanza Part Co.
it's the clinic that I use called Stanza 1 in Mamelodi.
Ki ile clinic ki tshwere ka tse pain ki bleed madi.
When I went to the clinic, I was in severe pains and I was bleeding.
Taskanda verify.
I then opened the file.
Dabataru chetse re bothata nga ke.
I explained what was my problem.
Barindie line ndio bombiwa.
They said I should go through the line for screening.
Velenda jena ka moari nda bombiwa.
Then I went through for the screening.
Da wana sister ulanda mutaru chetse re nne ndi na bothata mini.
I saw a nurse where I explained what my problem was.
Arindie ndi for a line yo ya ka doctor.
And I was instructed to go follow the queue to the doctor's room.
And then the for ane fala nangu ndi dronge ndi bleed ya toilet ki chinja.
And I continued to follow the line as I was continuously bleeding heavily, and I had to constantly go to the bathroom to get myself cleaned up and changed.
Aswa une ma doctor ba chaisa nandi satu jena ka moari.
To a point where the doctors had to knock off while I was not attended yet.
Abu jena zi sister za manjuyano.
And then it was the time for the night duty staff.
Ki mo ne ki jena falani ka zi sister ki bataru chetsa baru why ne ki sabulera from wange fairan.
So when I explained to the night duty staff, they said to me why I did not explain myself as I was arriving during the day.
Ndababuzo ki village from reception.
I told them that I have tried to explain myself since from the reception.
Bambuzo ndi the afternoon.
They said I must come in the afternoon.
Ki mo sister kan ne arindie emergency.
And then the nurse then instructed me to go to the emergency room.
Kan it in emergency bandie ndi renge pregnant test.
Then from the emergency room, I was instructed to go and buy a pregnancy test.
Nda tsamaya ki dronge ya nda jumpa skontiri nda ya shoponi ya makula.
I walked, I was feeling dizzy, and I went to the shops and I bought the pregnancy test.
Then
I came back to the clinic. Then I gave it to the nurse. And then she instructed me on what to do as she was checking my pregnancy. And then she asked me if I knew that I was pregnant. I said, yes, I knew.
Hospital.
And then she told me that I have to quickly go to Mamelodi Hospital. And then she said they were gonna put a drip on me.
nda ri okay a wu na mulandu
I said there's no problem.
a vhele va nghenisa drip
Then they did put the drip.
va fonela ambulance
They called the ambulance.
ambulance ya da ka vo 29 u bva ka vo past 5
An ambulance was called from 5 o'clock, but only arrived at 9.
ka niti nda namela nda ya daha
Then it took me to Taga Day Hospital.
nda swika daha falani va namedza wheelchair va nghenisa ka muwari
Then when I arrived at the hospital, I was brought in by a wheelchair to the emergency room.
nda tula until i ri 12 o'clock
I waited there until 12 o'clock.
hu sina doctor in checkout
There was no doctor that was attending to me.
ke busende khantitsi doctor dzi ile kae ka mo
I kept on asking, what's happening there? Where's the doctor here?
ba ri doctor ke e one ine ya ba ka mo i khou shuma sizana
They said there's only one doctor in the hospital and he's busy at the cesarean room.
nda ri okay mara nna ke kwa bothoko
I said, okay, but I am in severe pain.
ba re e bane le rutshi mo a huna ntho ine bone ba nga ira doctor's thing
They said you just need to remain seated as there's nothing they can do before I can be attended by a doctor.
ka nnete nda tula till doctor e tshita
And then I waited until the doctor came.
ke mo a tsamaya le rena ya re checka
Then went to the doctor's consulting room where I was checked.
sika nenge nga ngomu nda mu vhudzisa nda ri ke bjani a re awa ke sharp
Then I asked the doctor what's happening and the doctor said, no, everything is fine.
ke mo a re ke jike ke buye morao
And I was discharged to be sent back home.
nda ḓa nda tula kha wheelchair
Then I went with a wheelchair
until i ri 5 ya matsa
until 5 o'clock in the morning.
through
In the morning.
5:30 ba ndischarge
Then I was discharged at 5 a.m. in the morning.
nda vhusa ndi ri wa le ndischarge ke so ngori a ke right
Then I asked, why am I being discharged when I'm like this? Because I'm not feeling okay.
ngori le sithare le sesiwane a le ya mpha kana philisi a le ya mpha ke drip fela
Because I also asked that because you did not give anything, no medication, you only just put a drip on me.
ba re ke do ba sharp
They said I'll be okay.
ba re ndi tsamaye ndi ye hayani
They said I should go
ka
home.
niti nda tsamaya nda ya hayi
Then I left to go home.
ba ndi sike nda ira le ntho le ewo nda shuma ndi swike ke robale vele nda swika nda robala
They said to me I should not do any duties at home. I must just try to rest.
ka niti ke robetse yona mo
And I tried to rest the whole
e re
day.
bo ma past 5
So I went home and then I slept, but around past 5 in the afternoon,
ka thoma u ṱangana na worse nga maanḓa
then I got worse.
ya nkhapeletša uri ke buyelele futhi kiliniki
Then I had to be forced to go back to the clinic.
ke mo ke founela bomakhi ba dana di khombelo le nthuse a ke na maanḓa le ngise kiliniki
Then I called my neighbors asking for assistance because I was then very weak.
vele ba ngisa mo taxini ba mpherekeza kiliniki
Then they took me via the taxis back to the clinic.
ke mo ke swika kiliniki ke khumana doctor lan
Then I found the same doctor I met earlier yesterday.
o a mbodzisa uri na ke nyakane mo
The doctor asked me, what am I doing here?
nda re why o mbodzisa so
I asked, why are you asking me
a
that?
re yena o tseba uri nne ke sebadela ke daga
He told me because he had referred me to Taga Hospital.
nda bo ndischarge ka jeko fru
I told him that I went there, but I got discharged this morning.
a re why ba o discharge o se right o rwala
He asked me why I got discharged, what I'm still feeling sick.
nda re nna ke tsebe
I said, I don't know.
ke mo ntho tse nda ba ke na le tsona ndi dzipangile ka mo container ya ice cream
So by that time, I had brought everything that came out of me in an ice cream container.
ka ya nda mo sumbedza tsona
I showed it to the doctor.
a dovha futhi a re ke o vuyedza mo daga futhi
And the doctor said, I'm taking you back to Taga Hospital.
nda re a huna mulato
I said, no problem.
a fonela ambulance
They called the ambulance.
ambulance ya daga 9:30
The ambulance then came at 9:30.
ke letšatši la botho
That's the following day. That's the second day.
vele nda ya daga
Then I was then taken
swika
back to
daga ba re
Taga.
ke nyaka ene
They asked me what I wanted there.
nda vha sumbedza container iḽani ine ya vha ḽi something ka muhari
I showed them the container of the things that came out of me.
vha ri why nṋe ndi swika munḓuni nda swika nda bereka ngori vho mbudza uri ni sike nda bereka
So they asked me why when I got home I did some duties when they told me just to rest.
nda vha vhudza uri a ke a irasile ndo vha ke robetše
I told them that I was not doing anything, I slept as instructed.
ba ri bona ba sa tsebe gore ba tlo ira ene ka nna
They said they don't know what they're gonna do about me.
ke mo ba re tulane mo
They said I must wait.
ke mo ba nkisa ward 5
They took me to the ward.
ba re ba tlo mvalela namusi
They told me that I was gonna sleep over for the night.
ka nnete nda robala ona
I slept there.
ka mo furong
In the morning,
ra ya ra fura line yo kurumagiwa
then we then queued for the line where they said they were going to do cleaning.
ke mo ba mbudze uri hu balile
That's where they told me that I had lost my
nda vha
child.
vhudza uri hu balile bjani ngo doctor o mbudzile uri baby i rutshi right
I asked them how come, because yesterday the doctor told me that my baby was fine.
ba ri bone a ba tsebe
They said they don't know.
nda re mpito ke e botlhoko thata wa le discharge ke so le sa thoma la ntowela la bona uri na ke ra bjana
I then said that my heart was very painful because why was I discharged when I was like this before I could be observed and they could check what was really happening with me.
ke bo ne nne nda dira ka tshumelo ya Mamelodi hospital uri Mamelodi hospital a itshware balwadze botse
That's where my concern is, that Mamelodi Hospital is not treating patient well.
mbirwange e botlhoko thata ka lebaka la taba yo e re mo bora moya wa ka ndo ke a tsibudzisa uri na ho e re ya eni hune le dzi doctor le dzi sister dzo balelwa uri dzi nthuse
I am very hurt with what happened because I keep on asking myself, Uti, what really happened if I had went to the hospital, but nurses and doctors could not help me.
changa chiro tshi ḓo vha tshetsho
That is my concern and challenge.
amen
Belinda, before Usisi comes in, there is Usisi, the first one, who went to Stanza Bopape 1 for a prep and Tune, and you never got services. Even today, our guys told, we do have our party here who will assist you to make sure that tomorrow you go back there with their assistance to get the services that you need. Thank you. You may proceed, Belinda.
Dumelang bo botlhe.
Greetings, everyone.
So na problem ya ka inile mo eleng hore I was with my partner
I had a problem where I went to the clinic with my partner.
and when we got there we found that the clinic was shut down. Go Kabo Clinic Winterfeld.
We went there and we found that the clinic was closed in Khabo Clinic in Winterfeld.
We had to spend more money for transportation
We had to then spend money for transport
to another local clinic mo Mabopane, Bokonot.
to come to the Mabupani Clinic in Bogonont.
When we got there, we needed to test.
When we got to the Bogonont Hook, we were asked to test,
And the result is our partner yaka, they were positive.
and my partner's results came out positive.
The nurses tsa teng ba thoma ba bolela dilo tse o tshwanang le hore why tshwantse ke nne le motho mo beao.
And the nurses starting saying to me, why must I put myself be in a relationship with a person that is positive?
And yeah, ba ntse ba mpotsa hore ke sa le monyane and I still have future. Ke mo tlohele.
And they told me that I was still very young and I still have a future ahead of me and I should just leave my partner.
By that time ne ke le one mo council room yena na tswile.
And by that time I was alone with them in the counseling room. He was instructed to go out.
Ka nnete after that incident ka mo tlohela.
Then I left him after that incident.
later on mo bophelong ka bona hore go possible hore o nne le motho o nang le HIV and still relationship ya teng e tswelle pele.
Then later on, I learned for myself that it's possible to still have, live your life with somebody that is living positively with HIV.
So concern ya ka ke hore why ne ba sa offere di service tsa bona pila ba re fe information e ne re e tlhoka instead hore ba ntsele di decision.
So my concern is that why were we not offered proper counseling and give us information of what we needed to do instead of them making decisions for me?
Thank you. Dumelang. Na challenge e ke nnileng le yona ke ile ko Tlamelong clinic ka 5 o'clock as re itse hore he re ya clinicing tshwantsho re tsohe free.
So I attend Tlamelong Clinic and I usually get there as 5 o'clock, as we all know that we have to be very early when we go to the clinic.
E re tsena re ema line ko ntle ha gate ba bula di gate ka bo 7:30.
When we arrive there, we wait in a queue outside and the gates will be open around 7:30.
Then has no ba bula ka mahare re ema hape. And has no re ema hape ba re o nyake file.
And when we get inside, we still join the queue, and then after waiting for some time, we'll be told to look for your file.
He ke fitla ko filing ke sa ema hape more than an hour ba re ke eme ka ema.
When I arrive there waiting for my file, I still need to wait for almost another hour.
Then after he ke kra feedback ba re file ya ka e teng ko bula hape file e nngwe.
And then they came back to me and told me they can't find my file. I need to go and open another file.
He ke ya ko filing ko bula file ke sa kra ile queue e nngwe hape tshantse ke me queue e nngwe ya ho bula file.
When I go to the admin window to open a new file, then there's still another queue where I must still wait.
Then ka ema ka bula file ka ilo ema ko re emang.
Then I followed the queue until it was my turn to open the file, and I got my file and I went back to rejoin the queue.
Hence re me mo queue nese wa tla wa re botsisa one by one hore we not loetsang.
So as we were waiting there in the queue, the nurse came to us, asking us one by one as to what are you there for.
Then ebe ke responda but ke responded ko class ka re ke nahana hore ke na le infection.
So I then responded, but I was speaking with a very low voice to say, I think I have an infection.
Then even nese ela a shouta hore bolella ko di mo he le dira dilo tsa lena le dira le open.
So then the nurse shouted at me saying, can you speak loud, because when you do your things, you do them openly.
Then a line ya fitla ka tsena ba ntlha injection.
Then I continued with the line until it was my turn to get into the consulting room. Then they administered an injection to me.
Then he ba fetsa ba mpotsa hore ke ka ko ema line ko dipilisi.
Then they told me I have to go and queue to go to the pharmacy.
He ke fitla ko teng still ke line hape.
And also when you get there, there's another queue.
Ka ema line he sno ke ema line he sno ba fitla monna ba mpotsa ba re a ke na dipilisi ba nkwalla prescription.
Then when I got there by the pharmacy, they told me the medication that was there, it was not in the facility. They were out of stock for the day. And then they wrote a prescription for me.
Thank you.
Sanibonani.
Greetings.
Mina ngibe nenkinga engazihlangabezana nazo eClinic 2.
I had a problem with Stanza Clinic 2 in Mamelodi.
eClinic 2 in Soshanguve.
Oh, in Soshanguve, sorry.
Yeah. So ese ngithatha treatment ya my ARVs and then ngiku CCMDD.
I am on art treatment on the CCMDD program.
And asthma.
I also take my asthma treatment.
So manje kuba nelinye ilanga they phoned me eClinic.
And then on the other day I was called from the clinic
Ukuthi ngize eClinic ngizobabona.
that I should come to the clinic.
Mangifike eClinic they told me ukuthi kawu kanti wena uyithatha phi treatment yakho because efilini yakho asiboni awuzi lana uzo collector treatment.
They told me, they asked me where do you get your ARVs because on your file you have some time you have not been coming to the clinic.
So mina ngibatshele ngithi no, they've referred me ukuthi ngiyothatha e-pharmacy every time, and then even now ngiyacollecta nayi ikhadi liyasho ukuthi ngicollecta ngeyingakhi nangeyingakhi.
I told them that I've been decanted to an external pickup point, and here's my card showing that I do go and collect my treatment from the external pickup point, which is a pharmacy that I've been decanted to.
On that day, I spent the whole day bafunana ne-system ukuthi kanti kuza njani ukuthi mina ngithathe i-treatment, but ku-system yase-clinic appear kubo appear ukuthi as if mina ngiya-defaulta, and then meanwhile mina ngithatha i-treatment kahle from the pharmacy.
So on that day, I spent it almost the whole day in the clinic when they were still trying to find out why am I not registered as a patient that has been decanted.
So mina kula le challenge kungayo yona leyo nkinga leyo bathi ngiyo-collecta bang-register bathi ngiyo-collecta e-pharmacy again.
Then I was then registered to go and collect at the pharmacy.
Ngelanga le date mangifika e-pharmacy bathi amapilisi wami akakafiki angakabi registered.
Then on this next appointment, when I went to the pharmacy, I was told my medication was not there and I was not registered there as a patient.
So ngasuka futhi ngahamba ngaye clinic ngayo-reporta the thing ukuthi awukanti ngiuza kanjani because last time when I was here ningifonele and nathi ningiregisterile ngicollecte e-pharmacy. Mangifika e-pharmacy today i-medication yami ayikakafiki.
Then I had to go back to the clinic and explained what had happened because my medication was not in the pharmacy while I was here, and I thought the issue was resolved.
Bangitshela ukuthi i-system mhlambe beyi-down ngizame ukuza kusasa, and then kuwo wonke lamalanga la kunama-piece job enginowenza, so mangiloko ngicela umsebenzi uyagcina ungiphelela because I'm not working a permanent job.
So that then caused me a problem as a person that is working on part-time basis. I have to always be excusing myself to attend to the clinic, and I ended up losing my job because I have to take more days going to the clinic, as on these days I was told to come back tomorrow again.
And then so kule issue lena bayisolva kwaba ukuthi next time mangifika ngiza for i-consultation ye-psych. For a psyche, a problem is psyche.
So I was told that next time when I come to the facility for my mental health challenges,
Mangfanting funung igutolagale ifile lami alzang iltolagale. But in last week ibeng logo ngkhona la ngilo ngenza ama up and down ngalelo file.
so on the following week then they could not find the file. That was very strange because I was there just a week before to the facility several times, but then on this occasion they could not find my file.
Mase balitholile mabalifuna le file bathola only the cover, but phakathi akuna next, and then I'm a chronic, and no Dr. Fante azi ukuthi what is the program progress ye chronic yami le challenging nayo chronic.
There was then a problem because by the time they discovered my file, they could only find the cover and there was nothing inside. And the doctor needed that information to be able to see my progress.
And so bangitshela ukuthi ngiyovula ifile kula ngababuza khona ngithi ngivula njani ifile because udoctor ufuna the information akafuni ifile yokuthi ngikhona la eclinic ngigula ngiphethwe yini, ufuna ukwazi the history yokuthi inkinga yami yini, because lo doctor beko udoctor awumusha abamreferele lapha eclinic yethu.
So I was then instructed to go and open a new file, but I asked them, how is the new file going to assist in the process, because the doctor was new and the doctor needed my medical history.
Mangikeda ngithe ngiba ngiba emotional ngabatshela ukuthi alright, if you don't help me so ngcono ngiye ku manager mhlambi ifile lami lizawuphuma.
So I then got emotional in the process and told them that if you do not want to help me, let me go to the manager of the facility. Maybe I will then get assistance with getting my file.
jiki amathumbu wefile wama avela.
And then in that process, then the inside of my file came out.
So niyabona ukuthi ama-facilities lawa abadlala ngathi baloku basenzisa ama-pen down sihlale the whole day and then bangas-assist. They don't want to just assist us.
So you see then that in the facilities, they're just making a mockery of us because they can assist us. They do not just want to assist us. They just like to having us going up and down unnecessarily.
Ngiyabonga.
Thank you.
We are going to recommendations. You know, yesterday I spoke a lot, and I don't intend to speak a lot. But if we are to speak the truth, district and the district, province and the province, we've got similar problems. Mr. was part of our meeting yesterday, and I'm sure some of the things that are being said here by the community, both in person and on video, are similar to the things that were raised yesterday. Which actually shows that as the people of South Africa, we've got a problem with our healthcare system. There are certain individuals within the health system who do not deserve to be in those positions because they do not have the best interest of the people at heart. They treat people like animals, even in animals like pigs, where the dignity and the rights of the people are always infringed. But also this issue of the missing files, I spoke a lot yesterday that people living with HIV, we were told that people living with HIV are registered under tier.net. And we do not know at which stage does this tier.net works and when it does not work, to an extent where when your file is missing, now they are unable to go to the system and retrieve whatever information they need from you. But also, the other problem that we have is around the data capturing and cleaning of the data, where one will be decanted to the external pickup point, but in the facility, if data is not cleaned, you keep on receiving messages that you have defaulted. Yet, with pickup point, you are in line and you are adhering, which makes majority of people to fight with their families. Because you go to the pickup point to collect your medication, few minutes upon your arrival, either you receive a message or community health care workers comes to your home and say you must visit the clinic, and you end up not knowing exactly what is the problem. And also this issue of staff attitude. We know that our government is not hiring more healthcare workers. As the result of that, they are overworked and overburdened. Others have family problems. Then they bring those family problems and stress to the clinics and vent out to the innocent people who do not know what happened into your house last night or what is happening in your workplace. And this is a problem. Then the other thing, we call an issue assist paikoneni. Dacela ba managers, please let's sort it like issue assist. And any other person who goes to the facility and ask for PrEP services, because the National Health Act tells us that no one may be refused healthcare services. But Usisi was refused healthcare services. What does that mean? It means her rights and the rights of other citizens are often violated. And the problem that we have in South Africa, the National Health Department, The huge budget of the health department does not go to purchase healthcare services and goods. It goes to pay for medical legal claims, where they make mistakes, wrongly diagnose people, or do that or that or that, and people end up taking legal steps against the department, and the department ends up having to pay lot of money. And this can be avoided because the money which is paid for these medical legal claims is not coming from heaven. They take from the money that was meant to buy medicines, hire more nurses, fix our clinics, buy medicines, and this money goes to somewhere else. And I'm asking myself, what are authorities doing to curb this? You know, I am also a member. I'm a board member in the Office of the Health Standards Compliance, which works together with the Office of the Health Ombudsman. Then, when you look at the complaints of people going there, you begin to ask yourself, are we in a free country or we are in an apartheid state where black people are ill-treating other black people in a bad way? I thought white people hated us. But we as black people, we hate each other more than how white people hate us. Because majority of the people who are sharing their stories here are not being served in these clinics by white people. They are served by black people who are impatient, who do not care about the rights of the citizens. And it cannot go on like that. Something must be done, because if that is not happening, you know, in one clinic in Eastern Cape, Port Elizabeth, NU11 clinic, a patient is staying front opposite the clinic. He went to the clinic to get services, and the nurse was rude to the guy, insulted the guy, without the nurse knowing who this guy actually stays opposite. The guy left the clinic and went home to fetch his firearm, went back to the clinic to deal with the nurse. The clinic was closed for 3 days. And everybody blamed the guy. Nobody blamed the nurse and the attitude she demonstrated towards the guy. And we as people are different. Same applies to the nurses. One day a nurse will ill-treat a person without the nurse knowing what the person is going through, and the person decides to do something else. This is not only for us as patients. It is also for the nurses, as to say, you must respect people irrespective of its gender, race, creed, or affordability, or class. Other people are being chased away in clinics and be told, go and wash. That's what is happening. More especially to people who are recovering from drugs. When they go to clinic for services, they are being often told, Ningamapara, go out and take a bath. This is what you are subjected to. And the reason we have invited the district management and officials is for them to assist us in sensitizing the nurses, to remind the nurses about our rights as the patients, to remind the nurses about our rights as the citizens, which are enshrined in the Constitution. There is no nurse or official, even the MEC or the minister, none of them has ever taken money out of their pockets to build a clinic, to hire a staff, to buy an ambulance, to buy medicines. We are all here taxpayers. We are contributing towards tax, whether you are working or not. When you go to shop and buy airtime or buy anything, there is VAT. It therefore means we are contributors to the tax. And at times you feel like some of the nurses, they think that they have made it in life. And when we go to health establishments, we are not going there to ask for favor. We are going there to exercise our rights, which are in the Constitution. And when you get there, you realize that, my rights have been violated. And as a result of that, it makes other people not to feel comfortable to go back to the same facility again. So these are some of the problems that we need to address, comrades. We're going to recommendations. The Gauteng Department of Health should produce an annual report on the number of healthcare workers per capita employed in each district. Include the numbers of people and size of areas covered by these healthcare workers, year-on-year comparison from at least 2021, and the cost of these posts to the government. Fill all vacancies in 2023-2024 financial year. The Department of Health should extend facility opening times as per the 2019 National Department of Health Circular, utilize appointment days and times to ease congestion. Ensure filing systems are maintained in an organized manner to reduce lost files. Open clinic grounds by 5 a.m. so that people can wait safely in the mornings. Ensure files are not required for facility pickup points. People living with HIV must go directly to the pickup point to collect their ART refill. Support more people established on ART to be referred to external pickup points to reduce congestion. PEPFAR should support in filling all vacancies at PEPFAR Operation Putuma support facilities in the short term. Provide additional staffing for all PEPFAR supported sites to extend opening hours from 5 a.m. to 7 p.m. on weekdays. Fund adequate numbers of adherence club facilitators to allow for the restart of the adherence club. VETS RHI should immediately do an assessment at all PEPFAR Operation Putuma support sites with waiting time over 3 hours and develop a specific plan for each facility that will bring the waiting time below 2 hours. Support the facility to organize and maintain an organized filing system. Ensure files are not required for facility pickup points. People living with HIV go directly to the pickup point to collect their ART refill. Support more people established on ART to be referred to external pickup points to reduce congestions.
The next group of issues are now ARV collections. The revised 2023 adherence guideline note that time constraints.
Yeah, it is. Even with you. People need to talk today it's better. Yes, yesterday was.
Okay. Sorry about that. Constraints are a challenge to many people living with HIV. They go on to say that efforts should be made to support people living with HIV with suppressed viral loads to receive extended ARV refills and or be enrolled in a repeat prescription collection strategy. Implementing this as vital to supporting improved long-term adherences. Ritshidze data reveals 64% of PLHIV interviewed reported getting 3 to 6 months ART refills this year in the city of Tshwane. This is an improvement as compared to the 57% getting a 3 to 6 months refill last year. However, it remains below 71% in Mpumalanga, which is the best performing province monitored by Ritshidze yet. And far below 80% of people living with HIV in 21 other PEPFAR supported countries reported to get 3 to 6 months ART refill in 2021. Of people living with HIV interviewed by Ritshidze, 32% collected at standard medicine dispensing, with 48% collecting at a facility pickup point and 20% using an external pickup point. And of people interviewed, 12% more are using pickup points as compared to last year. For those using standard medicine dispensing, 58% said they have not yet been offered the option to use pickup point. Then all stable people living with HIV should be offered a range of repeat prescription collection strategy options as per the national adherence guidelines. Further, 23% of people living with HIV interviewed said that they would like to collect ARVs closer to their homes if it were possible. There needs to be enough pickup points to decant people into, especially linked to peri-urban clinics. In terms of adherence clubs, these options have been devastated since the onset of COVID-19. Most clubs have been suspended or reduced to being just a pickup point. We maintain the functional adherence clubs play an important role in supporting ongoing treatment, literacy, and peer support to help people living with HIV on treatment. Importantly, in order to be effective, repeat prescription collection strategies should make ARV collection quicker, easier, and more satisfactory for people living with HIV. Yet this is too often not happening. 63% of our facilities monitored, said that people using facility pickup points must collect files, take vitals, and see a clinician before getting their parcel. And 70% of people living with HIV said that this is the case, adding to the delays in the facilities, basically. Now we need to move to the recorded stories.
Bese ke bangibhalela incwadi ukuthi lawa selaphelile ngiyakhamba ngiya e-Dischem ngiwathatha khona. Ngichuzile ngathi la eMamsmall ngoba ngiyakhona ukuhamba ngeenyawo, ngiyakhona ukuthumela abantwana bayongilandela.
Thobelana ke monna ka Mustafel Park, so ke tsa di-ARV mo ilore ke na le problem ya go bona ka re clinic ya rena stanza 2 like o ka re a ena province mo e leng gore o gopola like vele right through vele tsa dipilisi mola mo e leng gore mo reception like ke pleke e lebeletseng kwa ko pele, and then the community like in so mo e lore like ke ba tsia medication wa bona like o molomo wa bona mo e leng gore o a leng go pharmacy o paka that medication on top of the files, and then a be mo banking o don't know pila these things o tsia go bia hona mo, and like everyone wa bona o ira halang. So iwe manyana because sometimes iba sharp like ho gro auna ho lebella mola ona like motho o itseng, but sometimes o khona ro ye mo lo grona lo mongwe wa community yona side ela lena mo, sometimes ke tsama le school bag mo lo ke za mo ka fitla wa utlwisisa, but still he lo, and then he ke mola o ntse mola mo banking obvious wa bona how that guy tse trebana mo lo so ba ka zama 12 plus the pampiri zo ke fila ba rawo o ka ba ka ona because this straff mo lo no go one at least o le ka ona mo at least since I'm bank this scam vele ke tell this scam about problem challenge iba yona or sometimes ba khona for 2 months go, and then after 2 months also boele hona like he go hopola next month o ka re tshwantse go boele mo ile no next year Ritshidze ne ke itse rago yona mafelong e feletsa vele e push or batho ba feletsa ba tshabo na ta medication.
Dumelang.
Greetings.
Na bothata ba ka ke itse ke tsena ka clinicing stanza 2 ba re shuwe wa HIV and ba tshwara ba mpha dipilisi tsela ka matsogo.
So when I go to the clinic at stanza 2, they give me my medication without any package.
Ka di tseya ka re wa o sa di phuthele.
I asked why was there no package for my
A re wa o sa tla
medication.
le school bag.
I was asked why I did not bring a bag to put my medication.
Ke a leboha.
Dumelang kaofela.
Greetings.
I use stanza 1 clinic in Mamelodi.
I'm attending Stanza 1 clinic in Mamelodi.
The problem here, Mamelodi, or the challenge and the experience that we are experiencing there, go to the files are on late.
The problem that we have in Mamelodi is to get our files late.
Or if it's like about 5:30, 6 o'clock,
We start queuing at the facility around 5:30 to 6.
we wait for them or probably like at 8 o'clock or 7 o'clock or whenever they want to.
We wait for the facility to be open, sometimes at 7, sometimes at 8 o'clock, depending on whatever they want to do.
And then when they open the clinic, they just chat, eat.
After the clinic has been opened, the nurses will be inside talking and eating.
I remember in July when I visited the clinic for the checkup,
When I went for my checkup in July,
I waited there for 4 hours. 4 hours.
I was in the facility waiting for 4 hours.
And then I kept on telling people to go inside because I didn't have a file on that time.
I kept on asking the people that were in front of me that already had their files to go inside.
And
Because
then-
I have not received my file yet.
And then I was number 2 on the queue.
And I was the second one on the queue.
And then when the guy aning asebenza mon afeta, I asked him, where is my file?
When one of the staff that is working in the facility passed, I asked him where was my file.
And then he referred me to another lady. Yena ha sebetsi ka di file tsa rena, motho a sebetsang ka di file ke ngwanyana o ba reng ke Lerato.
And then he referred me saying he does not work with the files for chronic, and he referred me to another lady working in the same facility.
And then when the lady afeta,
When the lady came,
and then ka mo emisa ka mmotsa ka re, "Ausi, I've been waiting here for 4 hours for my file."
and then I told her that I've been waiting here for almost 4 hours for my file.
Guys, that lady undermined me.
And I got very undermined from
And
the
then
lady.
even the look you could see, hore, it pushes you hore o kwate.
Even the look that she gave me was a look that would
He never-
provoke somebody to be angry or react.
She never even answered me.
She did not even respond to my question.
Aya ka mo clinic, ka mo hare ka mo room.
She just went inside the room,
I followed her.
and then I followed her.
Inside myself, I said, "You don't know who you are acting with."
As I was proceeding, following her, and I told myself that this lady doesn't know who she's dealing with.
And then I went there.
I followed her.
I shouted on her in
And then-
front of everyone.
And then I shouted in front of everybody.
And then she looked at me again, undermining me.
And then she gave me the same undermining
I
look.
asked the other guy, I said, "Where's the manager?"
Then I asked for the manager.
And then she showed me, said, "Go to room 4."
And then I was instructed to go find
And
the
then I
manager
went
at
there.
room 4.
When I just opened, I didn't even knock.
I just went there and I just opened the door. I did not even knock.
And then I told that manager, I don't know if it was a doctor or it was a manager of the clinic.
I just went inside. I didn't even know if it was
told-
really the
I
manager
told
or it was
that
the
guy,
doctor.
I said, "O bue le staff sa hao."
I just said to the guy that was in there to say, can you please address your staff?
When they were looking for the job, never sehlefaditse melomo.
I further said to the guy that was there to say, you must address your staff, because by the time that they were looking for jobs, their lips were dry.
Yes. So now they got the job. They are giving us bad attitude.
Now that they employed, they are giving us bad
And then
attitude.
Amputisa Aruna, what happened, Mama?
And then she asked me to explain
I
what had
told that
transpired.
doctor or manager, I said, "I've been waiting for my file for 4 hours. And then I kept on jumping again. Now I'm impatient now. Because ki chronic, you know when you have diabetic, you've been there for 4 hours, you're hungry, you never had food when utwa high.
So I explained to the guy that was in the facility what has transpired, and by that time I was already very impatient because I'm also diabetic and I have never had anything to eat in the morning for the 4 hours that I've waited in the clinic.
And then ke bona ba mpoditse ba re ebile ha o na le sukiri ha o tla mo tleliniking o ska ba ja hore sukiri ha o tle re kgone ho testa yona e be tlase. And then re a ya re sa ja ba re sukiri tla ba ko tlase.
And then they are the one that told us not to eat since we are diabetic when we come to the facility, so that when we get screened, our sugar level will
And then
be low.
ka botsa manager hore ka re ausu o le yena Lerato a mpotsa a re no mama ne re tlhoka a re na file ya hao, and then ne re nahane ho bulela file e mpšha.
And then Lerato was then called in and she said that, no, we cannot find your file. We're still trying to open a new file for
So
you.
ka mmotsisa pela manager wa ka re if I didn't act, no tla mpotsa neng hore you are still looking for my file is lost.
So I asked in front of that manager to say, if I did not react the way I did, when were you going to tell me that you cannot find my file?
And then a ke tloga mo bo bula a new file. Haina history ya ka. So which means they are predicting hore okay history ele so because una dipidisi tse so le tse so, then we are just going to give because it's a new file.
Then the new file was opened for me, but it didn't have any of my medical records, so everything was done through assumptions.
Guys, I have 5 files, stanza 1. 5 files, new files.
Currently in stanza, I think I have 5 new files.
Even on the 14th of this month, I went there.
Even on the 14th of November, I was in the clinic.
So they don't have my file still.
Still, they cannot find my file.
And then I waited again. And then after the doctor prescribed me the medication.
Then I had to wait through the same process, and then when I was consulted, the doctor then prescribed my meds.
I went to the medicine storeroom.
Then I went to the pharmacy.
It was full.
It was full.
I went back
Looked
to
well.
Lerato. I went back to Lerato.
Then I went back to...
I said to Lerato, Lerato, you see now, it's 20 to 3 now. I'm very hungry. So I think your attitude will help me to get the medication quickly. So you go and take the medication for me because I'm not going to queue again.
So I then went to Lerato to say, see, it's already 3 o'clock that I'm here, and with your attitude, I think this time it will help me to get my medication quickly because it's full on the dispensary and there is no way I'm going to queue again.
And then I was angry. She showed me that I'm angry.
And then she saw that I was very angry.
And then she took my medication and went there.
And then she took my file.
She came back quickly.
And then she came back quickly.
And then I
with my
told her,
medication.
imagine if it was me going there.
And then I told her, imagine if it was me going there.
And then she said, sorry, mommy, next time we will try to be quick.
And then she said, sorry, we'll try to be
The
quick.
toilets at Stanza Pape, they are very dirty.
The toilets in Stanza Pape Clinic are
You
very
go to the
dirty.
toilet and then it's a health institution with nurses who knows that you need to be clean.
In the Stanza Pape Clinic, the toilets are very dirty, but there are nurses there that knows that the facility needs to be clean.
Re se- ha re tswa ko toilet, ha re tlhape matsoho. Even if you have an apple, you have to eat it like that.
So when we come from the toilets, there is no water to wash our hands.
No, the taps are not working at all.
Oh, the taps are not working, so there's no way for us to wash our hands.
You can slip your saliva down. You cannot swallow madi mo fatshe ka mo toilet because di a nkga, ha di sebetse. You know, guys, please, lona batho ba health department ba ba leng mo, the manager, please help us.
This is my plea to the Department of Health to please assist us with the toilets in Stanza Clinic.
Batho ba HIV, batho ba all chronics, ha ba thabe ko ditleliniking.
We as people live with HIV and people who are also taking chronic medication are not really pleased with the
Re
facilities.
kopa le ske la tla fela la tlo tseya di information or report and then ha se be le ntho e le e etsang.
We are asking that you should not just be here to just get the information and take the report and then not do anything about it.
Please act on that, ke a leboha.
please do something about it. Thank you.
Sanibonani. Mina ngingumuntu othatha medication ye high blood.
I am on high blood meds.
Yeah, stanza 2. Ngibuye Mamelodi stanza 2.
I'm also using stanza 2 in Mamelodi.
Ngibe patient yakhona isikhathi eside.
I've been a patient there for the longest of
Mara
time.
ngibe nenkinga ngoba ngingumuntu ohamba kayosebenza makufanele ngizokuthatha medication yami ngiba ne problem.
So I do encounter some problem because sometimes I'm not there. I go and look for jobs somewhere.
Mangabe emsebenzini banginikeze ilanga ngiya estanza ngifikela ngingayitholi medication ungavuka ekseni ube selayinini ekseni ngabo labo 5 labo uyokuphuma ngabo 4 bakunqamula ilayini bathi isikhathi sakho siphelile iza ngakusasa.
I do encounter problems where if it happens that I get some day off from work, I would go to the clinic and then I'll queue from around 5:30. I'll leave the facility at 4 because they will cut the line and say, we must come back tomorrow.
Ngicine ngiyilisile ngikhamba ngikhipha imali ngikhwela ngiya edrobheni ePitori lapha bathini kanale eseduza le mawusuka eStiefbek bathini eTshwane sengithatha medication yami eTshwane ngelibanga lokuthi ngisaba ukulahlekelwa umsebenzi.
I ended up having to buy medication for myself to an extent where I self-transferred myself to a clinic in Pretoria because I was scared that I'll end up losing my job because of the situation in Stanza Clinic.
Ngibe nobhuti wami futhi engamthatha ngamisa khona eStandard Pape HIV.
I also took my brother that was HIV positive to Stanza Pape.
Ugcine kushuthi angaphathekanga kahle.
He also did not receive proper treatment.
Wagcina ayekele ne treatment.
He ended up defaulting from his treatment.
Wagcina lahlekile namhlanje lesangimazi kuthiwa yapi.
He ended up disappearing from home up to today. I do not know where my brother went.
Ngiyabonga.
Thank you.
Dumelang le kae?
Greetings.
Yeah, na ke na le problem ke motho wa o leng hore ke tsa ARV.
I'm on ARV treatment
Go Hebron.
from Hebron Clinic.
So tsatsi le lengwe ka date ya ka.
So this day I went to the clinic and it was my appointment date.
Ya ne ke lwala ke tshwere ke tlhogo.
I also had a headache on the day.
Then ka ba botsa re man a ke right ke tshwere ke tlhogo.
I told them that I'm not feeling well. I also have a headache.
Then man nese amputsisa hore you startile ning tlhogo.
They then asked me, when did the headache start?
Ke re ka tšeo ke letsatsi la bo 3.
I said it was about the 3rd day.
Are you? A o ithate abuti. Letsatsi la bo 3 o tshwere ke tlhogo ke hona o tlo tla ka tšeko.
And the nurse said to me, you do not take care of yourself. If you say you had a headache 3 days ago and you only come into the clinic today.
Kore no, hore ke emele letsatsi la ka tšeko. Ne ke bona hore date ya ka e mo haufi. Nka se tle go tleliniki 2 days before and le ka letsatsi la bo 3 ke boe hape.
I then explained that I just realized that my day was just in 2 days. My appointment was just in 2 days. So I can't come to the clinic in 2 days and in 2 days time come back again just for a headache.
Then ke gara abuti ha o ithate. Ke no ka ithata sis.
And the nurse continued telling me that I do not love myself.
Because na mo ne ke tseya ko teng treatment. Ne ke re ha ke tla ka bolwetse bo bo. Then ba mfe that treatment continue treatment engwe e tla be ke tletse except ARV. So now why le na le behavior?
So I did explain to say where I used to collect my ARVs, if I come in the consulting room and I also tell them that I've got another problem, they would attend to both the illness that I presented on the
Ara
day.
abuti wa itse keng o dlala ka rena ntle ke na kofi yona e a tlhogo bile nka se e kwale and then o tla boa the following day.
And then she said to me, I'm not gonna give you any treatment for your headache. I'll just give you ARVs, you'll then come back tomorrow to consult.
Then ang kwalla tsona tseo ka tsamaya and then da go so the following day ke boe.
Then I was given my ARVs and I left, and then the following day I had to go back to the clinic.
Ka boa ba mfa di panado tseo.
I came back and I was given Panado.
Then ke concern ya ka eo e ke nyaka go erase hona.
That is my concern with the facility that I want to raise.
Okay, we are going to recommendations. I am told, Provincial Chairperson of TAC in Gauteng, Comrade Bonabis, I'm told that there is an incident at Stanzabo Papi a week ago, if not early this week, where a nurse was insulting a patient in front of every board, and that patient never said anything. He took a chair and used it as a weapon to attack a nurse. As much as we do not support that kind of a behavior, but can also the nurses be sensitized and be made to understand that we are human beings and we need to be treated with respect the same way they expect us to treat them with respect. Chairperson of TAC in Gauteng, I am also told that there is a clinic here in Mamelodi where a cleaner is bullying everyone, including the facility manager. Today, I need to get a report at least by Monday as to say, how have you dealt with that cleaner? We cannot have cleaners here who are ill-treating our people as if these clinics belong to them or their family. The TAC branch in Mamelodi must convene a meeting with the facility manager and that cleaner must be told, when people are speaking out, she must stop taking the files of the patients and hide them. We cannot have that situation. This is not a banana republic. This is a democratic country. We cannot be treated like this by individuals. Please. And if it means you must escalate the matter to the district director, please. And we must name and shame now. And not talk about faceless characters. We cannot. Before I read the recommendations, I'm not talking politics, but politics is all about us and our living conditions. If you read books, all countries that have started revolution, even in Cuba, even in France, French Revolution started when people were fed up and they were not taking it anymore. They decided to start a revolution. If in South Africa, it means a struggle to bring about the social and economic challenges of our people must start from fixing the healthcare system. Let's start a revolution. Let's start a revolution that will, because, after these meetings, when you are sitting alone, you become traumatized. Listening to all these stories. Last week, 3 days, we were in KZN. And this week, we are here. Same stories. And then you begin to ask yourself, why did great leaders, Abo Stephen, Bandu Biko, Oliver Tambo, Osobuku, you name them all, why did they die? Did they die for this? We are being oppressed by the black people. Our own blood are the ones who are oppressing us, because we fought for affirmative action, we fought for this and that, which made them to occupy senior positions. Now they have forgotten about the people. So it is up to us as the people. We as the people, we have the power more than those in positions of power. We are the ones who have the power. Even this weekend, they were going house to house, encouraging us to go and register. Why? Because they know that we've got the power. They know that we've got the power. How do we use our power to change our lives and our living conditions? Because we cannot accept this, where we are given rights and our rights are always and often violated by people. I am not encouraging people to fight or do anything that is illegal, but we need to correct this by engaging with duty bearers. You know, before we started Ritshidze, TAC used to picket and march. And I always kept on asking myself, why TAC comrades, when they go to clinics, are wearing their HIV positive t-shirts? They were like, no, GS, this is a strategy. If I am in a hurry, I want to go somewhere, I go to the queue, and I'm wearing my HIV positive t-shirt, a nurse will pick me there and say, come and help you, because they don't want us to see these things. If it means, as branches of TAC now, and Ritshidze and all other organizations, we need to give people t-shirts in order for them to get quick and quality services, let it be. But we need to apply all strategies, Chairperson. Let's engage with the MEC after all these meetings, but it does not mean that we must sleep. Let's tell the branches to go back to facilities, monitor our facilities, fix the problems, because some of the things that are reported here is what was collected 3 months back. Now we need a quick response on challenges that are facing people. You are being ill-treated today. What is the turnaround time to address that problem? We cannot wait months and months to address this problem. A person does not get treatment today. A person is ill-treated today, that needs to be resolved on the same day. We need to name and shame these nurses. If it means we must take their pictures and put them across the community so that the people can know them, if it means we must put their faces on social media in order for the community to know them, let it be. But at the end, we need to convene a meeting with their trade unions. We need to meet in a house, Denosa, all of them, and tell their leaders what their members are doing to the community, which we cannot tolerate anymore. The recommendations are as follows. The Department of Health should implement extended ARV refills at all facilities to 3 months by end February 2024 and 6 months by end September 2024. In order, our clinics are overcrowded. And the majority of the people who go to our clinics are stable people who are going to collect their treatment. And we do not know why the Department of Health is not speeding up the process of giving people who are stable on their treatment multi-month dispensing of medication. If I am given 3 months, it therefore means the next 3 months I won't go to the clinic. I will only go after 3 months. But now, every month you must go to the clinic. Yet there is a policy which has been signed. I think this is one of the things that we need to be talking about with the Minister of Health and the Deputy President on the 1st of December in Durban. And from there, we need to see how do we roll programs that will put them under pressure to make sure that each and every clinic is giving people living with HIV and chronic medication 3 to 6 months supply, so that we do not end up going to these clinics every month and be shouted and insulted by the nurses. The Department of Health and vets, RHI, should ensure all people living with HIV are offered a range of repeat prescription collection strategy options, and those enrolled in pickup points or clubs are active. Ensure that reassessment of pickup point option takes place at each clinical consultation to ensure people living with HIV remain satisfied with their pickup points or clubs. Ensure all facilities Implement the 2023 Adherence Club Guidelines Standard Operating Procedures with fidelity, including ensuring facility pickup points are a one-stop, very quick ART collection only, visit under 30 minutes. No need to go to the registry, collect folders, see clinicians, and etc. Ensuring re-establishment, implementation of quality adherence clubs, including group facilitation component. Increasing the number and type of external pickup points to ensure urban, peri-urban, and rural clinics have external pickup points. Ensuring people going back to clinics for their pickup point rescript receive the rescript on the same day if clinically well, to ensure no unnecessary additional facility visits, with effective recall system to action any abnormal results or elevated viral load. PEPFAR should monitor and hold accountable PEPFAR district support partners to implement 2023 adherence guidelines standard operating procedures with fidelity.
The next group of issues are on art continuity. People living with HIV lead complicated lives and may well miss appointments and even miss taking some pills. When they do, meeting them with support when they return to the clinic helps ensure long-term adherence. But often, when people living with HIV and key populations return to the clinic, they are treated badly, leading to people disengaging from care. A differentiated service approach is required for people living with HIV who re-engage in care. Some will require intensive clinical management, including advanced HIV screening and management. Some will require psychosocial support in the form of quality counseling and group support options. The majority needed to be made easier to collect treatment. These people should be offered multi-month dispensing and should be assessed and offered access to pickup points or adherence clubs as quickly as possible. Implementing 2023 re-engagement clinical and adherence guidelines are vital to supporting improved long-term adherence and retention. VETS RHI should support the remaining 30% of facilities and all others in the district in training or mentoring on the changes in the new 2023 adherence standard operating procedures. Ritshidze data reveals that out of 2,095 respondents, only 58% of people thought that the staff were always friendly and professional. This graph shows data across time since data collection began in the district. The district should urgently improve to ensure that all people living with HIV, key populations, and other public healthcare users are treated with dignity, respect, and compassion at all times. It is also important to note that because Ritshidze interviews take place at the facility, people who have already disengaged from care due to poor staff attitudes, some of which we heard from today in our community stories, would not be at the facility to interview. The best performing sites are outlined in the table. And here are the worst performing sites. Out of the 57 people living with HIV who had missed appointments, 39% said that staff were welcoming when they came to collect ARVs if they had previously missed a visit, but only 4% said that staff counseled them on adherence. 25% said that staff still send you to the back of the queue the next time you come in. Yet, according to the National Art Guidelines and differentiated model of care standard operating procedures, people should not be sent to the back of the queue or made to wait until the end of the day to be seen. A returning patient should take up the next queue space. The guidelines specifically state that no punitive actions are allowed. People should join the queue as normal on arrival at the facility, irrespective of whether on time or late for their appointment. Punitive actions lead to people deciding not to come back again. We need to normalize late and missed appointments without penalty. People who have come back despite being late have made it easier for the health system. It is not necessary to track and trace them and encourage them back into care. The person has stepped back into the facility willingly so that the experience should be as supportive as possible. While most people did not report transfer letters being a challenge, 54 people interviewed by Ritshidze had been denied access to services for not having a transfer letter across 17 facilities over the last year. While this is a low proportion of all public healthcare users interviewed in the district, given that most people interviewed are unlikely to have attempted to transfer services, it points to a larger problem regarding the communication and policies regarding transfer letters. A reminder that transfer letters are not required in the guiding principles of the re-engagement standard operating procedure, which states, if a patient comes from a different facility, it is critical that the patient be provided with treatment on the day of presentation. While referral letters are helpful, a patient cannot be required to leave the facility without treatment. 83 people interviewed by Ritshidze had been denied access to services for not having an identity document across 20 facilities over the last year. All sites should be urgently investigated. Again, it is important to note that Ritshidze interviews take place at the facility. Therefore, people who have already disengaged from care due to challenges accessing a transfer letter or not having an identity document would not be at the facility to be interviewed. Psychosocial support is another critical element to ensure long-term retention. Ritshidze data shows that only 68% of people living with HIV interviewed know that psychosocial support is available. Further, a full package of psychosocial services are not yet available at every facility. A full package of services should include provision of individualized, quality-assured counseling to patients, peer-led patient navigators acting as a bridge between clinicians and patients, mapped networks of referral services, optional support groups, and food parcels. As part of psychosocial support, support groups should also be linked to each public health facility that are critical to provide counseling and support services to people prior to testing, post-testing, pre-treatment, and those struggling on treatment or re-engaging in care after a treatment interruption. Treatment literacy also improves art continuity as people understand the importance of starting and remaining on treatment effectively. Of the 755 people living with HIV surveyed, 96% had received a viral load test in the last year, but only 81% of those people reported that they knew their viral load. 89% knew that having an undetectable viral load means that the treatment is working well, and 86% knew that having an undetectable viral load means a person cannot transmit HIV. There is still room for improvement to reach other higher performing districts where as many as 100% of PLHIV understood why an undetectable viral load is important. 4 facilities had perfect scores where all people living with HIV understand why an undetectable viral load is good for their health. However, other facilities performed worse. Four facilities also had perfect scores where all people living with HIV understand why an undetectable viral load is good for ensuring you cannot transmit HIV. However, again, other facilities performed much worse, including only 27% of people who understood in Dark City CHC. We will now move to the recorded stories.
Ka re ke le positive fela ba o ka thamotse ya medication aka ke tsamile ke ntse ko tseya o right ke sena le bothata mara problem mantso a re a kry-ang ka mo tleliniking wa ya tleliniking ho le ko tleliniking a kere ba kgone go fa ba re ke 6 months ebile 6 months ba ithomile mo morago mengwageng ya e tlang ko moraonyana ba re ba o fa bana ba re fa di 3 months ba boa gape ba o fa 6 months neng ba o fa 3 months especially ba ka bona gore viral load ya gago e kontwe e ko tlase a kere CD4 for count ya gago maybe e ko dimo and bothata keng a ba o tla se o tlhalosetse le gore CD4 count ya gago e tlela kae o tlisisa or viral load ya gago e mo kae so lo bona nako nngwe ka re ke ira ka kry lore viral load ya ka ya ba ko dimo ke bile ke sa tlhaloganye gore viral load pila ke eng a ke itse even today ntho ba reng ke viral load a ke tlhaloganye o nkutlisisa ke CD4 count le yona ke no itse ba re CD4 count ya gago e nameletse ba re a wa kora gore o right mara a ona le motho a ka o tlhalosetsang gore gape CD4 count ke eng viral load ke eng ga o di understand dilo tse bane ka tsona tseo a wa tseo ke a di bona go ntse o ya o tshwanetse o bone doctor ba o fa date ya gago ke date ya doctor wa ya kwa gore doctor at least a kgone go bona ho ya o tletse nako mme ba go slow or go irala o panla go fa doctor selo o eme o ntse mo di bankeng o tsene furu ka 7 e be di bethe 12 di re 1 e tshwanetse o ye ko doctor ba tla tlisa file ya gago ba lengwalla ba re ya pharmacy tsamotsa dipilisi a o bone doctor gore wa ba botsa manesa le ba tla o chika ba o irang a ba bolelwe wena pila o tse wa la fra fotlheliwa re a ona gore pila ntho ke thabelang ka mola a go monata ke go botsa mala gore lo ya tleliniking o ya go a maoto se lo bona nna go nngwe ebile ka ba ka felletsa ke sai o nkutisisa ka default mara ka bua hape ka re mara why ka re bophelo bo ke baka ka ya ka wela e go wela ba nthoma hape mathomong mara at least o kere lore ke tswella pele mara nthwela ba ira e sa tswella pele a bile ke thabile lo ya tleliniking a o thabile ene o no isa fela ke tabaeng bophelo ke ba hao o ka se nne o re wena o e tleliniking ka baka la gore wa lwala gore last year sele a mpotsa gore pharmacy ya mo kaufi ke feng ka mmotsa ka re pharmacy ya mo kaufi ke discam ke bona le discam e teng ko Mom's Mall mara since a sentse ke bone doctor
So still usanka go
ke sa ya tleliniking nna ke nna tlhokaina ke dula gona mo Lusaka ke tsamaya tleliniki both stanza 1 and stanza 2 ke bile le problem last year ke lo belega ke biditse ambulance go tla ambulance and then go itla ambulance ba ntse ya gona problem ke thoma ke tsama ko dag ke kra bo sister ba ba shoga ka 4 o'clock ene ko le wa HIV ene wa tlangole mo flusang ke na HIV ba ishe gona ko batho ba di HIV so ya se ntshware pila ka belega foroga ke fetsa go belega ka ko bona ka bo 7 o'clock na go tsheba discharge ke nyaka go tseba rena o tsena ke eng ka batho ba HIV ke a se aga ke ka bana ke ne le yona ke aga a se ka ra batho ba motho tsore ke HIV ka mafaseng wa bona so ka thotana le ena ba re o tlo mo kubisha mmere ko ngwe e bolela fase ka re ka se mputsere ke bolele fase e swana le ena mabana ka bolela ba ke ba di HIV o ya bona so ke tswe mo yona this year mo stanza mo tleliniking re isha bana ke isha setlogolo ko tleliniking ke fita ko tleliniking ke line ba go file nomoro maybe 103 so le tla bona se bana tlo la bona mona kana ke tsene tleliniking ka 7 o'clock ke to tsama ka 4 o'clock a mpotsa re tlo change the date so I ntshware pile because ha ba berekishi batho pele
gore le gona le file sometimes o kgona go ya ko isitse ngwana ka file ba go botse gore a ba bone file ene ba tlo go wena ba go tlhalosetse gore a ba bone file ba ne go mola a ba botse until ka bona botse gore ke bereka jwang ba ra re bone file ga ne nka be bana ba kgona go bea batho ka di-appointment gore ba di-appointment tse di so batlanenneng ba bee di-file tša bona for status sa HIV gore mogala ba ka o checkile o positive so mogala ba ka ke nna ka molatong dipilisi so mogala ba ka kgona gore ka eya kwa ba motšea madi a ba mmotse selo a ba mmotse ba why ba motšea madi go iragalang o ne bereka boare ba ntšere madi for eng a bolele next gore go iragalang wa bona unless ye ya maloba ka laboraro last week o re kerile Dr. Lekgowa ke ena go mo tlhalosetša a motšea madi a mo tlhalosetša gore go iragalang ke bone ke lona ka re o botšiše because o ntse re mare di-result di a boa santse o ntlhalosetse gore na ke nwa dipilisi pila go iragalang ka nne ko startile treatment ka 2019 o ne tsewa madi a ba mmotse selo bare a lena le rata go robalana nna re rata go robalana le tla mo letlela prep ka mofaseng re rata go robalana no berekiša condom because ba mmotse gore prep batho ba rata go robalana like gore motho wa HIV o ne HIV go ne AIDS so bona ka moka dino swana motho ka tshwere ke HIV o ne potsa gore ke tshwere ke AIDS mogala ke ntho mogala ba be phele le molemi a re mo se ke tshwere ke AIDS ke ra wa tshwere ke AIDS o tshwere ke HIV go ka tswela pele ka dipilisi tlo no stika gona mo go HIV so ka ba ntse dipilisi ka gore dutse ka mo a ke tse wa go tlhalwana ko stanza ka mo go ba dulang ka ona le faster mo tswa medication ba no bia gona mo le batho ka mo ka ba go lebela to tswa medication o ARV so I sharp ba re tlo ba di bia gona mo le ka mo kgodeleng ka gona ba tlo go fa tsona dile ka mo go ba tshele ka di plastic one like it's only STI kone STI angre ba ncheka for STI ke tla be ke tlhalosa di sign tsa gona gore STI ke bona 1 2 3 mantsi a tlo gona go robalana le na le robalana le be condom a le tsore STI jang is a problem so bona batho ba bantsi ba relapse ba sa kgone go boela ko clinic batho ba change di clinic ke potsa ke le west ga ne go tswana ke le kae ka go tswana mara ba tshwana di clinic tse ka moka tse di tswana le sepetlele a gone different a ba re feng di-date tse re botse se ka ra pakalana di-clinicing ba re fe di-file re bula di-file every day ebile re bula dipampišana matšatša ga re sa bula di-file ke pampišana ba e tlogela le ka mokgolo
bangitshela ukuthi kose ngizothatha i-medication yami ngokudosa igazi into eyangixaka lapha sister sis angeke uthathe umuntu igazi ngapha umbophile and umfake inalithi ngapha ukhuluma nefoni umuntu loyo omfaka inalithi akeze ubuhlungu ngapha ukhuluma nefoni nama-boyfriend manje sike mina ngalo ngathi phela anginjengemuntu ngisubuhlungu and ngapha ungibophile isandla sami wathi akaqeda ukunuka nje igazi la spade and akangincengi uyangiruthula nento leya akayincengi uyayiruthula igazi la spade ke ntse ke boletse gore ne ke tsaya treatment ya di-ARVs and then ka baka la mathatanyana ka tlogela and then ke ya ko tleliniking ke ba tlhalosetsa gore ke sale ka tlogela and then ke nya go tswela pele ka treatment ba mpotsa gore kone no ntse o tlogela o itla and then a fetsa o tlogela e re o referele ko social work and then social work hela ke ya kwena ko ra mpotsa the way ke le useless ka gona so ene a ya ntshwara ka ga botse tabeng cause mathata a phela le batho go le motho nako nngwe wa tshwarega le ge ntse o inwa medication nako nngwe date bongwe le tseng yona o kane maybe wa kry-e le gore o tshwaregile and then kore a sa bolela le nna ga botse kore ka mokgwa boletse le nna ka gona kore nkare ke letlakala fela so wa kwešiša and a ya ntshwara ga botse tabeng ka nthonyele ba mfa o nthušitše mara like o nrogile kore like o nthušitše but a nrogile o kwešiša cause le bona ba santse gore a re gane re batho re ira diphošo phošo ira ke motho ya boa lokiša ke motho ba santse gore ba ithute go bolela le batho cause ba bereka ka batho okay ka wela back go sister and then sister amfa treatment and then no ke sharp ke tsama treatment ya ka gabotse ba mfa 3 months ko clinic go sister ke nna ke kgopela gore ba ithute go bolela le batho cause ba kgethile mmereko ba tse gore ba tlo bereka ka batho a re gane motho o na le mathata mara nako ngwe ka no tloga ko gae o tshwere ke stress mara stress sa gago se šie ka gae o tseba gore ke tlile mmerekong ke tlo bolela le batho o tlo bereka ka batho
I feel like I have privilege. ntho nngwe le nako mo e leng gore still motho khona o tswana ka nako mo e leng gore sometimes ke a try ke tswe ka bo ma 3 o tsise ke botso re cover up a line but still lo tswa ka 3 o'clock o bua ka 4 o'clock mo e leng gore a khona tlhalwanya re problem e ba ka ke eng mo e leng gore o tswa lata o tswa ka 4 still o bua lata go rana na go e leng gore ka zama ro push gore re ke tswe fru and then ke khona o bua ka pele still hono ba slowly mo ile ka na go bo botso ra na since re ya lunching like sometimes o thoma na go tsa low shading le ona go ba staraga mo ile gore challenge.
I'm staying at the extension 6 at Ritshidze. I'm going to Pumulong clinic usually. My first issue here, I'm taking my medication there. I'm a chronic person, taking my HIV treatment there, and so my problem is one. I came there on the 21st of August. It was around 9, because usually I go by around 6. I'm tired of going there in the morning, because of when I go there around before their working time, I go out around 3 o'clock going home. On off, which is wrong. I can't stay there for more than 6 hours or 5 hours. When I enter there was a sister there making a lot of noise, telling the chronic people, not people, chronic people, we are only working, we are only 2 ladies here. When we work, we are under pressure, and if you can't wait more than the hours that you want, you can go home. Because even us, we are having a trouble of the assistance. That's where I was stuck and look at her, and what is she saying? I just questioned myself. I couldn't go there because we are going to make an argument. Firstly, you can't tell the patient we are only 2 person working there, and you can't chase the people away, because when they are there for a purpose, for the reason. That's why my complaint is that they must treat the patient nicely. If she wasn't rude, she was just talking polite, I was not going to complain. Don't be rude on the person, and don't tell them so like you are chasing them away. If you can't wait, you can go home. No. Firstly, it's rude. She was saying that because of the other patient just enter and tell her inside the room, it's been long that you are waiting. That's where she got angry and came out and tell all of us. If I was having my own money, if I was getting my salary, I was not going there at the clinic. No. I was supposed to go at private clinic or Ujani or whatever. That clinic, they are rude. It's just that the free medication is fine. I'm better with that. Please, man, nurse, treat the patients are nice. Certainly, you are bargaining your personal things. No. Right. If a person atla too much, attend them first. Personally, engwe ya gore motho o tla alwala too much lena le itse le go ga maoto ebile ne ebele khatele line le re lena le a dijong. Yes, le tshwanetse le dijong a ke gane mara ke eng e bang le botho cause le le nya ka mmereko la le nyoko thusa batho.
Na gore ke be mone sale ke be ne ke bereka ko Northern Cape ka ba le bothata le ka clinic ya Block X ka gore ne tshwantse ke ile go collecta dipilisi go clinicing ke le go Kimberley Northern Cape ka shia card mo Soshanguve mo ke rela gore ke shela le ngwanyana ka khonong collectrela dipilisi and then a di se go Pretoria North ba di tseya ba tlise go Kimberley but go Block X ba hanne gore ke di kry. And then what's one or get gonna get chelete after 15 days ke sanu dipilisi gore batho ba le itse ba botsa gore ke tsamadi 3 months ne azang bampa transfer ne ya machomo ba ke ba boditse ba rene ko pele maybe wa itse bona tla ka ba mpotsa ba rene ko pele maybe le tla boa every month end Ko tla ba le no ko boela hape ka di 29 tsa yona kgwedi ya September ke sa itseng hore bontse ya madi hape hore bjang sister o na re wa nkomanya ke mmoditse gore hape sa le ka romela motho mo ba re why ne ke sa founele clinicing in which azang ba refa di-number tsa clinic e bona zang ba refa le ko khateng a di teng number tsa clinic ele o ya obviously the day ya o ya clinicing o ya o kwatile obvious o ya clinicing o ya o setse o kwatile gore ke date ya ka vele ai o ya o kwatile vele.
So it happened on the 24th August in my checkup go clinic. So I arrived there nearly 6:10, and then we waited until clinic ibulwa ba fitlhile, and then the nurse wa fitlhile pele ka 7 o'clock o ile a re tlhalosetsa a re yena o sebetsa ka bana ba under age ke tsa treatment ya di ARVs ke tsa treatment ya sukiri. So nurse fitlhile pele o itse okay rena re a thoma but lena batho ba baholo di nurse tsa rona di tlo thoma go sebetsa ka 8 fitlhile it was dirty Costanza Bopape one. And then ntse re dutse gona mo ditulo ba re nurse lo re file ditulo re dule mo ntse re dutse mo sepetlele nurse le ditshila le montle yena nurse. And then my concern go le di nurse tse batho ba ba sebetsang ko clinic they don't have name tags. You can't say hore ke nurse mamang aneng a etsa so o nkile le fielo a fiela ntse re dutse gona mo dust itla mo rena a di bokeletsa mo pela monyago. So ke dutse from 6:10 by 11:30 everybody necessitse a tshwere file ya hae ka mo letsogong nna ne ke sena file 11:30 ka be ke botsisa abuti o mongwe a ntse a thusa di hontsha di card. And then after that guy ambotsa no mama me I'm working with another patient. The person who must help you with your file is that lady, the fat. He said the fat lady, and then he didn't even call her by her name. So when the fat lady comes, I said, sorry, Ceci, I'm still waiting for my file from 6:10. I understand we arrived early before you opened the clinic, but now it's 11:30. I still don't have my file with me. And then that lady just looked at me like this, like I'm stupid. I don't know how they take us. She just passes. When I ask her, where is my file? She passed me. Then I lost my temper.
Kenamo extension to Soshanguve. I'm a person with disability. I'm totally blind. About finding medication tarona, the bliss tarona, what they call legal sight in printing, about the braille. And then some of the bliss that in Dialican, Kamohara, the paget. And Africa Munkum, we won how bony, and we were on 2-3 times a day, and we were on 1-3 times a day. You end up with the mixer, or sanity, Catella, iling right. And later by communication, camera clinic. Habaiti who communicate alone about one disability. Whenever they talk to us, Barifa Atishuti, Baba shout abroad, it's even got an article and Lorona, they forget that we having a right, a right to health. But then it seems like they deprive us that right. Our daddy marshals, how no how to sang out Sakwan. And look from hospital to Pompey about with a doctor. Still again, all of the kifedits or cannot. Then Okravan Hutleti, Utulava to Honamola, then you end up Kabola to Babambo Pinning, Balalo, and Abamba Roha, Evangar Esifro Navano Rona, we are a bed and Kamaraki Nikritilo so good Sakamul. While we need help. Actually, doctor, now most of the time, but Mutanga did at Doctor Street. Yeah, now, Bonavan Bamfa now, one feel service Asia, doctor.
azange ka kry attitude from any doctor because like communicator le yena ke bolela bo yena at least bona yena khona o friendly and omfana ka re ke bolela nkutlwelle. I think clinic ho tlhokeha the workshop and then le ba staff because there's a shortage of staff and then later ba ya di file ha re for batla di file ba improve system ya bona.
Thank you. As we are going to recommendations, I think credit must be given where it is due. To say, according to this report, there are a handful number of clinics that are doing well on ART continuity. And we need to applaud those clinics and encourage them to do more and not to drop the ball, so that they can be able to set a barometer and an example to those that are underperforming. I think we need to applaud those facilities with the hope that they are not only performing well this quarter and then the next quarter they will underperform. Then the other thing which all of us here, even those who are watching online and those who are not here, we must agree upon. There are certain things that needs to be abolished, that we need to scrap them off and say, we do not need this one. Like, when Anele misses his appointment, and the next day when Anele goes to the clinic, irrespective whether Anele is early or not, Anele is made to stand at the back of the queue. That is not a standard operating procedure of the department, and it must be scrapped. Not any other day. That's why people living with HIV in the room and online, when you go to a clinic, you miss your appointment and you are told to go at the back of the queue, you must refuse. Don't go there, because that is not an arrangement of the department. It is an arrangement of certain individuals within that facility. Because you cannot be punished for missing appointment and nobody knows why you didn't come on the appointment day. Let's say today you are supposed to collect your treatment and the rain is falling heavy, and you know that your clinic is very small and you will be made to stand outside. Do you think I will go and wait outside on the rain for 3 hours? I cannot. It therefore means I must wait and go to the clinic on a day that is not raining, because my clinic is very small, there is no adequate waiting area. So that must come to an end. We need to abolish that one, ma'am. I think the HOD and the MEC will agree with us. We need to abolish that one. Then the other one is this one of transfer letter. You coming from Lusikisiki. In Lusikisiki, you got a call from your uncle, Gibela. There is a job opportunity. You must be here by Friday. And you get a call on a Wednesday. You need to find out where are you going to get money. You do not think properly. You do not think of going to your clinic and ask for a transfer letter. But one thing that you know, you must adhere to your treatment. You go to Johannesburg. When you are there, you realize that your medication is about to be finished. Because you want to adhere, you go to the nearest clinic. You are not given treatment because of a piece of paper transfer letter. Yet we were told of a tier.net. Why this clinic does not verify me on the other clinic? Because both of them are government departments. I am using ABSA Bank. I can go to ABSA anywhere in the country. This branch, they don't say to me, you never opened your account here, go to where you opened your account and get a transfer letter. You can go to Home Affairs anywhere, you will get services. But why in the department? Why? Because we are supposed to be having a department that is adequate and have systems that are in order and are user-friendly, because we need to understand the majority of the public healthcare users are poor people. How do you expect me to call another clinic, yet I do not have money to buy a loaf of bread now? You're telling me, you're sitting there, you've got a phone that is paid for by the department. Instead of you picking up a phone, call another clinic, you're making me to call that clinic or to go back there. Is that fair? We need to abolish this, comrades. And that's why it is important, community members, when political parties come to you and tell you about your manifesto, we must ask them, what is it that you are going to do to fix our health system? You cannot come to me and tell me I must vote for you, and you do not tell me how are you going to fix my clinic. We've got ward councillors who are quick to come to the fore when ward committee members are supposed to be appointed. But when we experience these problems, we do not see ward councillors. I think we need to agree with the MEC and officials ukuthi indaba ye-transfer letters and people being punished for missing appointments, this month is coming to an end. And if it is not coming to an end, I am saying this in front of the officials, that people must refuse to go at the back of the clinic. If it means you must start a fight there, nobody gets a treatment until I get my treatment, let it be. We must refuse. We must refuse to any mediocrity that is going to be presented to us, which is unjust. That is unjust. I cannot be. All of us here, we once, twice, or many times missed appointments, and we were never punished for missing appointment. You were invited to a wedding party or this or that, and something came up in your family, and you called someone to say, hello, Peto, I can't make it. Upeto understands that side. But we, as the users, when we go to clinics, nobody is prepared to listen as to say, why did you miss your appointment? They just conclude that you are one of them. Go at the right at the back of the queue. That needs to be abolished. And we are taking this also as one of the package to the Deputy President. Paul Mashatile, as the Deputy President of South Africa, is also the National Chairperson of the South African National AIDS Council with Joe Phaahla. Joe Phaahla is the political head of the health department. It therefore means the Minister of Health and the Deputy President must do something about this. And if it means that we're going to tell them that we're not going to vote until they fix these things, let it be. Because at the end, it's all about our lives, not their lives. Because when they are sick and dying, the first flight is taken from South Africa to Europe in order for them to get quality services. Yet here in the country, we do not get quality services. We need to fight back and change the system. It is only us who holds the power. We, the people. Not those that we have elected. And we need to demonstrate that by defying all the unjust laws, starting from this one, when you miss an appointment, you are taken back. When they say go at the back, you must tell them, Andi, I'm not going there. Either you close this clinic or you give me my medication. Recommendations. The Department of Health should ensure Department of Health staff acknowledge that it is normal to miss appointments and or have treatment interruption. People living with HIV returning to care after a late or missed scheduled visit, silent transfer from another facility, or treatment interruption should be welcomed. That's why we've got a welcome back program. But we do not see it being implemented adequately across all facilities. Ensure the Department of Health staff treat people in a dignified and a friendly manner, and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary action where appropriate. It must not be limited only to Ritshidze reports, but also reports that are coming from community. Something must be done. Send communication to all sites, highlighting that no person living with HIV should be sent to the back of the queue if they are late for or miss an appointment, as per national ART guidelines, where no punitive action should be taken. Ensure transfer letters are not be required for ARV continuation or restart. Any reports where treatment is delayed by requirement of a transfer letter should be urgently investigated and disciplinary action taken where appropriate. Department of Health and VETS RHI should implement the 2023 adherence guidelines and operating procedures with fidelity, including ensuring every person starting ART is provided with good quality fast track initiation counseling as session 1 at ART start and session 2 after 1 month on ART. Taking first viral load as early as possible to ensure providing earlier adherence intervention support and earlier access to longer treatment supply at more convenient locations. Actioning an elevated viral load without delay, including funding and setting up effective abnormal result recall system and providing quality enhanced adherence counseling when appropriate. Actioning as suppressed viral load without delay, focusing on immediate assessment, offer an enrollment into repeat prescription collection strategy of choice the month after viral load is taken. All facilities must implement 2023 re-engagement algorithm, including appropriately differentiating services for the returning of people living with HIV. Ensure the Department of Health and district support partner staff provide accurate and easily understandable information on treatment literacy and adherence, and the importance of an undetectable viral load through consultations, counseling, and outreach. Ensure that treatment literacy information is provided at health talks each day at the clinic. Ensure that Department of Health and district support partner staff explain viral load test to all people living with HIV properly in a timely manner. VETS RHI should ensure that district support partner staff acknowledge that it is normal to miss appointments and or have treatment interruption. People living with HIV returning to care are often, or after late or missed scheduled visit, silent transfer from another facility or treatment interruption should be welcomed. Ensure district support partner staff treat people in a dignified and friendly manner and investigate any reports of poor attitudes raised by Ritshidze and take disciplinary action where appropriate. Support with training and mentoring of Department of Health staff at facility level on the revised 2023 re-engagement clinical and adherence guidelines standard operating procedures.
Thank you, GS. The next group of issues are those affecting key populations. Most key populations are using public health facilities to access healthcare services, so it is important that our clinic and community health centers provide a friendly, respectful, safe, and confidential environment. Yet, despite sensitization training and retraining efforts, disrespect and poor treatment of key population remain a common challenge. Where people do continue to suffer the daily indignities of using the public health system, specific services remain unavailable. Ritshidze data reveals that very few sites provide key population-specific services, and when asked what those specific services are, it becomes clear that there is little available. Key populations can't always access basic prevention tools like internal condoms and especially lubricants. External condoms were only available in 83% of sites monitored, internal condoms only in 55% of sites monitored. Lubricants were only freely available in 21%, despite 67% of sites saying they have they provide lubricants as part of their HIV prevention package. Additionally, lubricants need to be put in places that people can take them without being judged, embarrassed, or outed as a KP. However, in the few sites where lubricants were freely available, often they were put in the main waiting area or by reception or by request in the consultation room. Positively, 17% of sites did put lubricants in a private space to collect them. Not all facilities prioritize offering key populations PrEP, despite it being available in 100% of the facilities monitored by Ritshidze. We now move to our recorded stories.
Ngahamba ngaye eclinic, ngihamba iclinic estanza 2. Ngathi ngiyile eclinic bengiyofuna iPEP. Bangitshela ukuthi ayikho. Silanana kakhulu. Fanele sizame ukuzivikela. Ngathi ngiyachaza ukuthi why ngizile ngizoyifuna. Bathi kuzomela sisebenzise ama condom because siza kakhulu la eclinic and siyabakhathaza. So ngabachazela ukuthi ngibengisebenzisile i-condom but yabhasta. So bathi ngeke bakhona ukungisiza because into engiyifunayo ayikho. Kwamele ukuthi ngijikele ekhaya because bengingananto engingayenza because bengifuna usizo from eclinic. Bangitesta for i-HIV but yathi negative. Bangifaka erumini bathi the only thing ebanganginceda ngayo ukuthi bangitesta i-HIV. So bangifaka erumini bangitesta bangitshela ukuthi kuzomela sizame ukuzivikela kakhulu. Uma iqueue yabantu bonke like la uyocala khona ufuna i-file. Then from i-file then uyoqueue kune queue yabantu like ngisho different abanye abagulayo then lethu iyona eyodwa yokuthi ufuna i-PEP. Inhliziyo yami ibebuhlungu because it was a risk. Angazi ukuthi kwenzakalani emzimbeni wami. What if into engiyikheshile mhlawumbe ulwelwe or anything else?
I am from Soshanguve and I am what you would call a trans woman. I'm under transition. It's been 3 months now. I'm on hormone therapy and I don't identify myself as a he or her or even a they. I don't put myself in any box. I would say I am non-binary. So the clinics I use is Tlamelong Clinic, and they have a section where we actually accommodated as the LGBTQIA community. So it is dedicated to us. That's the clinic I use. In other clinics, like the general clinic that we have, which is open 24/7, is in Block BB. It's very terrible. They do not treat us the same, and it's a terrible experience just going there because literally I end up leaving without getting help. I collapsed. I have a scar here. I collapsed and then they rushed me off to the clinic. When I got there, I woke up. That's when I regained my consciousness. And then after doing that, I could actually hear the sisters saying, oh, okay, but not hard, probably utility drugs or whatever. That's why I waited. And that was not the case. So after hearing them saying that, I woke up, got off the stretcher, I took my phone, I bolted back home. So I never went back there again. Yeah. So just because of assumptions that they made. I work a lot. I have a brain that is super fast. I even have to take anxiety pills to calm my brain down. Yeah, like they discriminated me because one, I show up unconscious with my beautiful hair and they don't see any breasts there, and probably that took them off, and it was something that made them probably uncomfortable, or it was something that was a joke to them. So I felt really insulted and not valued as a person, and what I came for was for my health and that was not even the issue for them.
Then when it comes to the clinics, that's where the problem is. First of all, when you go to the clinics, no matter you go with an emergency or some disease, a flu or something, when you get there, they're gonna give you a better attitude. Nah. Those people, I can give you an example. When I was going to fill in forms of by them of rehab, nah. When I got to the clinic, they didn't accept me well because I was smoking. Nah. Ba ile e ba botsa wa ba mputsa di question ne re wa tsuwa thomile neng ga ba tlhalosetsa wa o tšeletse sister o mongwe jana mpotsa re nna ya tsuwa di drugs ke emele wa a thushe batho ba e pele ne ka mutshare ba ra le nna mo se kitlile mo itle o tla o fila pa dilo tse le do thusha nna ka mafelelo ne ba mpotsa ka mkhwelo re ke boe ka osane tsatsi le o bona ba thusha bana ka bothata bo le re kopana le bona kwa ba ne patients a ba khone o tshwara batho pila ka bothata ba ditleliniki tsa borena mo hae na nwa ke sa ya rata ke tle mo ore ke tleliniking rata ke tle khosapo gore mo le di mobile di fela di tla di mobile di tla ba re treat with care ga bona o tsana a ba re o nna tsuba di drugs or nna ira ba re tshwara pila a besides khosapo ne mo ga di kry tleliniking ba ga sofi ba botsa di netle se ke tsa di patients tsa bona a se batho ba utsuba di drugs a re bothata ba e gore a agree service ene yena o va o ile o reng o tla fa community service.
Nna sister ne ke tsubanya ope ka yo nyaka thuso go tleliniking kwa sister batho ba le like sala bona batho ba o fella pelo sister ka ke tsela no mo nyaka thuso ba o ja o be ngwa le bjana wa bona sister ka banta teng sala mo kutsa bothata wa bona tswana le no le tseba bo tleliniking no makelo ala ke ratoya because of ba ntshwara wete le no ke ka tshaba pila ke tsama di clinic that's why ke sa rato tsama di clinic ana sister no ne ke kula ngona sister ke sa clinic ngono ke swa ke go botsama spetlele vela a ke dingwadise
Tamelong Clinic has got KP services for the LGBTQIA community, drug users, prostitutes, so sex workers, sorry. Yeah, so we really not judge there. Okay, we have PrEP. You can get PrEP. You can get tested there. We have referrals if you do not live in the area, where you can go and get your ARVs or whatever medication you need. So they basically a round off clinic which offers what a clinic offers. No, I get my hormonal therapy at Arcadia. It's in an organization called Access Chapter 2. No, I'm sorry, Orem. It's autumn. Yeah. So it's been 3 months. Okay. I honestly don't know that there were facilities that could actually offer hormone therapy. The good thing is if they find that you are positive, HIV positive, they start you back onto treatment so you live healthy and become the person you are in a healthy body. If you can check, what people don't know, they fear. And fear comes with certain reactions. So it's not just me, it's just everyone around. What they don't know, it just makes them scared. And the only way to react is with fear or insult.
Dumelang.
Greetings.
Hello.
Hi.
My story is I went to Maria Ranto Clinic. I went with my living partner and we had broke a condom, so it was an STI issue. So we are normally living with HIV together.
So I went to Maria Ranto Clinic with my partner when we had a condom bust.
So when we get there, we were told they were mocking us and violated us. Di nurse ne di bitsana, in a sense, ya gore tlhale boneng ke first time re bona a gay couple together and a kitse ba ira eng.
And when we arrived at the facility, the nurses were mocking us. They had called each other and said this is the first time they've seen a gay couple together. And they also said that they don't know what we are doing together.
And instead of giving us the help that we needed, ne ba seba mo passaging, and I felt gore ba ntloela, like really. So I confronted the nurse.
So instead of the nurses giving us the medical attention that we needed, they were busy at the passage gossiping about us, and I was annoyed and felt like this was not on.
After that, I confronted the nurse and it went drama. I called the manager. As much as I know, and I'm working from Access Chapter 2, I told them that they violated my right. I know as a humanitarian what needs to be required, and what they did, it's unprofessional. And I stopped going to the clinic drastically, period.
Tsatsi leo ke ile ka ba lata ka ba jwetsa gore ke tseba di right tsa ka as an activist working with Access Chapter 2. I told them that I know my rights and whatever e ba yentseng ko nna ne se sharp ba violated di rights tsa ka. And from that day azange ke sa pheta ke khutlela clinicing. Thank you.
Dumelang.
Greetings.
Ke berekisa clinic e ba e bitsang Themba kwa Manskrale.
I used Temba Clinic in Hammanskraal.
It happened a long time ago though. I think the first time I went for my STI checkup.
The first time I went to the clinic, it was for my STI screening.
Yeah. So the nurses automatically assumed that I am straight.
So the nurses ba ile ba nahana hore ke heterosexual.
Yeah, heterosexual. And then the moment when I told them I got this from the opposite sex, that's when they started treating me differently.
Ha ke seno ba tlhalosetsa hore actually ke nana ke thotse the STI from my partner, that mo ba thobileng ho treated differently.
Yeah, I got a lot of discrimination. I think that's the first time I faced discrimination at a clinic, and yeah, I stopped using it and I changed clinic.
Ke mo ke thomileng ho ba discriminated against, and it was very bad hore ka ba ka decide go tlhole ke ya ko clinicing eo and then ka change clinic.
Tumela.
Greetings.
I've been living with HIV for the past 19 years. 18 years is the 19th year from the ordeal of rape, and also survivor of cancer and pulmonary TB. What I've realized ke gore
Ke motho a phelang le bolwetse ba HIV for the past 18 or 19 years, if I can recall. Also ke survivor ya TB. Ke tsebe ke ka Sotho. Oh yeah, cancer, and also I was treated for pulmonary TB.
what I've realized and picked up, and I'm LGBTQ activist, what I've picked up ke gore we're not being treated with respect. There's still a lot of discrimination and stigma, especially in the health facility.
Also, as a member of the LGBTI community, I've realized that when I attend the clinic, we are not treated with respect and we are discriminated against.
Ke ne ke nka medication wa ka ko Sidilega mo di yo.
I used to collect my art treatment at CDA clinic at the extension unit.
Yeah, I'm block you. And what I've realized is that hence I've indicated that we're not being treated with respect. There's no confidentiality.
So go the clinic in Tahona, how na confidentiality.
What has surprised me is the other day I went to the clinic to go and get my medication. Yet I've disclosed I'm an activist. I find myself in one room with the other patient, being there at the corner with the nurse, and me again on the corner with the other nurse.
So holo hokana le ha ile hore khale ke le living openly le HIV, but ke ba surprise hore ha ke fitla ko clinicing ko roomong nurse di pedi mo thoko e nngwe nurse consult a patient e nngwe le nna I'm expected to be consulted mo thoko e nngwe in the same room le nurse e nngwe.
That's why I've realized Jorge, there's no confidentiality. What if maybe I didn't disclose and I'm there to take my blood results? Then the person start to lose focus on what she was doing. Then automatically she'll concentrate on me.
So ke mo ke reng clinic tsa rona ha ba respect confidentiality ya rona, because what if ne ke sa disclose status saka and tlamele ke bue about status saka le nurse motho o dutseng mo patient engwe e tlo lose focus for ntho e tletseng a qala o mamela ditaba tsaka.
Instead of fighting with them, I decided to go to Tshwane support group.
Instead of ke lwane le bona ke decidile hore ke tsamaye ke attend ko Tshwane support group.
Then I got advices. Then I was assisted gore ke tsamaye ke ye ko bokamoso mo odi.
Then ke mo ke thotseng thuso ya hore ngana ka ya ka ilo attenda ko odi.
And go odi I've been taking my medication more than 10 years.
So go odi sentse ne ke nka medication ya ka ho feta 10 years for now.
And it's the best clinic, especially bokamoso.
And then go odi ke clinic e right e sharp, especially the site e ya Bokamos.
And again, I don't want to say that one rotten potato spoils the whole bag.
Okay, I ke batlo gore le tapole le one le sieleng le bodisa matapole a mangwe.
But I was shocked the other day while I get there. I had the blisters on my private parts.
Mara tsatsi le lengwe ha ke fitla kwa ne ke na le di blister mo private part ya ka.
Hence, I've been taking my medication for a long time. I'm more familiar with a lot of infections that we come across.
Since ke bile motho nka treatment nako e telele sentse ne ke tseba malwetse a mangwe a mangata a dirahalang mo motho o HIV.
Then I get in the consulting room where I find a female doctor.
Ke ile ka tsena ko consulting room mo ke ileng ka thola doctor wa motho wa monna.
Wa mme.
Female, oh, wa mme.
Then when I get there, she was busy on WhatsApp with the phone.
Ha ke tsena mo consulting room doctor na le busy mo WhatsApp mo phone ya hae.
I waited for long for her to finish, and I could see that she was chatting instead of giving me attention.
And ke ile ka memella nako e telele and ke ntse ke bona gore motho o ipuela le batho ba hae ntle le hore a nake nna or a mphe attention.
Then she asked me, how can I help you, as they used to ask us.
And then a ba mpotsa gore nka o thusa jwang as usual.
Then I ke re mo ena ke re, yo ke na le di blisters, I think opportunistic infection.
Then ka ba ke re ko yena ke na le di blister, I think gore ke na le opportunistic infection.
And I also have abdominal pains.
And gape ke na le di pain mo abdominaleng ya ka.
What I've expected from her was to say go to the private room and undress.
Ntho ene ke lebeletse o yena gore a ngobele ko roomong and a njwetse maybe gore ke hlobole.
So that she can be able to check on me what is happening, especially talking about my private parts.
Ke ne ke lebeletse gore o tla nchecka, especially since ke mo jweditse gore ke na le bothata mo private part.
The question that she first asked me was that, do you condomize?
Umputsitse gore ke a sebedisa na condom.
I think it's a STI.
A re ke nahana gore ke STI.
Not because I know my sexuality. I know it might be opportunities is infection, because when we are in this state, sometimes the stress can create that.
So not because ke a tseba and ke understand the sexuality ya ka ke ile ka re ko yena ke nahana gore ke opportunistic infection and mohlomongwe e ka ba e trigilwe ke stress.
Then she didn't even bother to ask me such. Then she said it's transmitted disease.
And azanke a iphe nako ya mputsisa di question further o ile a nka seqeto ya hore ke STI.
Then I told the lady that I ke robalane.
Then I told her that I'm not sexually active or I'm not having sexual intercourse.
Believe you me, she never even bothered to say go to the private room for checkup.
Hazanke abatle hore an check lo check
She
privately.
prescribes the antibiotics, of which they always do that. She prescribes the antibiotics.
O ile fela a nkwalela di antibiotic and ntho e ke ntho e tlwaetseng ho etsahala.
So if prescribe the antibiotics without checking as to where do those blisters comes from, what are you trying to prove to me?
So if fela o nkwalela meriana o sa ncheka lo ncheka hore ka ba bothata ke eng, like ke tshwantse ke nane jwang.
Cause possibilities ya already those blisters di ka mogare, it might be high.
Because o ka etsahala hore the blisters tse bonahalang on my outside di ka be di le ka mohare.
And get very skeptical in terms of that, because I once had cervical cancer.
And ke motho a tlhokomedisisang haholo bakeng sa experience ya ka with cervical cancer.
So after getting that antibiotics, then I went out. But when I go to hospital again, when she's in the consultant room, I rather ask people to pass and go to the next consultant room, because I don't want to see the lady.
So ka bakeng la experience ya ka le doctor o ha ke khutlela ko sepetlele ke a checka if ile yena ka mo next room ke kopa batho ba bangwe hore ba fete so that I can go to a different room, because ha ke batlo attendwa ke yena because of experience e ke bileng le yona le yena.
And my thinking is that she behaved in that way because I was distracting her from talking over WhatsApp.
I think ke bothata bo bane because ha ke tsena ko gopong na bua ka WhatsApp.
So she wanted to continue to talk with her WhatsApp.
Oh, bothata bo ke nana bothata bo bile because ke mdisturbile ha le busy a bua ka WhatsApp, and concentration ya hae ne le ko WhatsAppong a jahetso a qete ke tswe a khone ho tswella pele ka WhatsApp ya hae.
Wisely, she was supposed to say, wait a minute, I'll call the next patient, not to allow me to come to watch her flittering on her phone.
Na tlamile a chilo ko rona hore ke kopa le eme ke tla le bitsa ke santsane ke le busy ka something, instead ya hore a mpitse ke tsene ko consulting room only hore ke tlo mo shebella a dlala WhatsAppong ya hae.
And hence I've indicated that Bokamoso is the best clinic. It is still the best clinic. If they can remove her and maybe show her the correct way of dealing with patients, it's still going to be the best clinic.
Jalo ka ke chilo hore bokamoso e santsene e le clinic e sharp fela ha ba ka lokisa batho ba nang le attitude in the clinic.
They need to prioritize us as LGBTQ, because people tend to have a negative mind towards us.
Hape ke nana hore tlamele ba re prioritize rona the LGBTI community, because batho ba bangata ba na le attitude e negative.
And people think that people who are taking ARVs, we are mad. We are not mad. We are normal. It's just that we understand our rights.
And there is this notion in our communities that people banana batho ba ba leng go di ARVs ha ba phela hantle mo ditlhaloganyong.
In that regard, I would like to say, Ritshidze, continue to do what you are doing and be the change that we want to see. Thank you.
Ke batla go seletsa ko project ya Ritshidze gore le tswelle pele ka mosebetsi o motle and le be change entle e rona re expectileng mo di community tsa rona. Ke a leboha.
Thank you. We're going to recommendations. The other problem we need to fight as the country is around stigma and discrimination. Because stigma and discrimination is what leads to many people. Stigma, discrimination, and the gross violation of human rights is what makes majority of the public healthcare users, be it people living with HIV, TB, be it LGBTQIA plus community, be it sex workers, be it people who are using drugs, they are often discriminated, stigmatized, and their rights are often violated. And because some people do not want to fight, they prefer to disengage and come up with other options as to say, how are they going to access healthcare services? Then on the other hand, you have the Department of Health. Currently, majority of these 100 facilities and other facilities are reaching out to communities in order for them to link back to care people who have disengaged. But the unfortunate part, I'm part of the technical working group of the Operation Putuma at the National Department of Health. These are some of the things that we keep on telling them to say, you're telling us about what you're going to do at community level, but you are not committing on what you're going to do at facility level to fix all the problems that led to people to disengage. Because it's a futile exercise to go and look for people to be re-engaged, yet the problems which chase the people away from the facility are still there. People will come for one day and disengage again. We need to address that. But also, South Africa is a democratic country. I spoke about the Bill of Rights, the freedom of choice, freedom of association, and all other freedoms. Therefore, it means it is wrong for healthcare workers when they are in facilities. Instead of them providing services to the people, they start preaching to people. Try to win the minds of the people to toe their line. Try to tell people that they will not go to heaven if they do this and this, as if the one who is telling you is holding the keys of the heaven. No one is holding the keys of the heaven here. So stop telling people or discriminating people because of their sexual orientation. Homophobia is equal to apartheid. As we are talking now in Uganda, Yoweri Museveni and his government enacted a law which is homophobic. As we are talking now, majority of the gays and lesbians in Uganda are being chased out of the communities. Others are being murdered. The same Yoweri Museveni is the one who is telling us that he is a Christian. What kind of a Christian that will encourage mass murder? And those healthcare workers who are discriminating against the LGBTQI, sex workers and whoever, they are not different from P.W. Porter, from Verwoerd, who discriminated black people because of our skin pigmentation. 1960, before 1960, black people were subjected wherever they go to carry a dompas. And if you were not having a dompas, you would have committed a supreme crime in the land. Until Robert Mangalso Sobukwe and his group decided to break the law. They surrendered themselves to the police to be arrested. That's why today we walk free, not having dompas or dombooks. And I think even in this case of stigma and discrimination and the gross violation of our rights, in order for it to end, we need to do something. I do not know what is it that needs to be done, but I know to say we need to do something to end stigma and discrimination that is perpetuated against the key populations, because we cannot tolerate a situation where people will end up deciding to disengage on care because of some rotten potatoes. Rotten potato, comrade, spoils the whole bag of potatoes. Those rotten potatoes needs to be taken out of that bag so that the bag is not contaminated with whatever that made that potato to be rotten. We need to work together with the department. Here and yesterday and tomorrow, we are able to bring to the department the people that they are looking for and say, here are the people. Here are the people here. And the people who have disengaged on care, they are telling their stories why they decided to disengage. Instead of the department coming to us and persuade us to engage on care again, we appreciate it, but fix your house. Fix your house. Because if your house is not fixed, we're going to come today and we will experience the same thing. We will go back home again. It therefore means the state will unnecessarily use resources to go and check people who knows why they are sitting there. We are not sitting at home because we want to die. We are sitting at home because we do not want to fight against the nurses. Because if each and everyone here had decided to fight against the nurses based on what they have experienced, what the country was going to say? Patients have adopted a negative attitude against the nurses. Without the country applying a need to know principle as to say, where does this attitude come from? This attitude comes from what the majority of the people are getting from those rotten nurses. And those rotten nurses are spoiling our health system as the country, and they need to be dealt with. The recommendations are as follows. The Department of Health should ensure that all clinical and non-clinical staff, including security guards and cleaners, across public health facilities are sensitized on provision of key population-friendly services to ensure a welcoming and safe environment for all key populations at all times. Key populations must be involved in the implementation of these training modules. Any reports of poor staff attitude, privacy violation, verbal or physical abuse or harassment and or of services being restricted or refused should be urgently investigated. The Department of Health and PEPFAR should expand the Center of Excellence model to ensure that at least 2 public health facilities per population in the city of Tshwane serves as key population designated service delivery centers. A minimum package of services should be made available at these facilities as outlined in the State of Health report. Easy referral and adequate resources, including transport or money for transport, must be provided for people to take up these services. PEPFAR must support these facilities with additional key population-friendly staff and resources to provide comprehensive health services to the specific key population being served. Ensure that HIV prevention tools, including lubricants, external and internal condoms, PrEP and PEP, are made easily available at all public health facilities. Make available external and internal condoms as well as lubricants in a range of spaces across the facility. For an example, waiting area, toilets, gate, pharmacy, consultation rooms, quiet areas out of sight, so that people can freely and easily collect them. Ensure that PrEP is offered to everyone, including key population who are not living with HIV or test negative for HIV, with information shared on its benefits. Ensure that all facilities provide gender-affirming services, including using trans people's correct names and pronouns, providing a gender-neutral toilet for trans people, respectfully asking trans people which color folder they are more comfortable using, ensuring that trans women are not made to use men's corners, maintaining privacy and confidentiality. Additional healthcare workers and clinic staff should not be called into a consultation rooms under the guise of helping, when often this is to mock and judge trans people.
Thank you, GS. The next set of issues are on infrastructure and clinic conditions. The country's load shedding crisis negatively impacts on the provision of healthcare in our clinics and can often lead to people waiting much longer to collect medicine or consult with a clinician. In the city of Tshwane, the most common challenges include data capturers not being able to capture information, creating a backlog in impacting follow-up with people who have missed appointments, and other recall systems, and delays in finding files when filing rooms are in darkness. Generators at each facility could resolve these challenges, yet only 64% of facilities reported having a generator that is working and has fuel. Only 52% of facilities monitored in the city of Tshwane were observed to be in a good condition, down from 68% of last year. The most common reasons of poor clinic conditions were due to buildings being old and in need of renovation. 73% of facilities reported needing more space, with waiting space, rooms for private HIV testing and counseling, filing space, and rooms for medical care, given as the most common things facilities needed is extra space for impacting negatively on congestion, TB infection control, waiting times, and privacy. On an overall cleanliness, 62% of public healthcare users reported that facilities were very clean or clean, while 5% reported that facilities were very dirty or dirty. These are the best and worst performing sites are outlined on the table shown. "72% of Ritshidze observations found that the toilets were in a bad condition, with no soap, toilet being out of order, toilet being dirty, and no toilet paper given at most common reasons." Now we move to the recorded stories.
Okay, nna ke nna patient ya ko clinic 2 ko di-G mo re bang le problem ya gore in most cases ha o tlo nyaka di-file go ba le queue e telele e tsamayang slow, and then re na le problem ya pape ya gore ha o tshwanetse re dipilisi ko pharmacy e tsaya sebaka se se telele, and at some point re na le gore ha o tlo checka file ya gago o kry-a file ya gago ba sa e kry-e, di-file di a latlhega. So go bonagala o kare go nyakega gore go be le file room tshwanetse ba e oketsa, e bonagala e le nnyane thata because di-file di a vanisha. Le mo dipilising gape tshwanetse le ko teng ba zama go dira gore plekela ba e bule e be e golo, so that ha ba lata dipilisi ka ntlhela ba di tlisa ko pharmacy go sebe wa ba le problem. And then clinic le yona pape ke nnyane, clinic la ke kgale le ntse le teng clinic e le ne re nagana gore if ba ka zama go oketsa clinic e la like mo purchasing mo lo go phela go tletse, but ke nagana gore clinic e la ha e ka ba e kgolo go ka sebele that problem, ba ka khona go thusana manese a le everybody, mara clinic yona tshwanetse ba e godisa because ke ya kgale tata. Yes, when I go to the clinic, one thing that I don't like with the clinic, I can go, maybe they open at about 7 o'clock. I'll leave the clinic around 12 or 11 somewhere. I'll be wasting a lot of time. That's why I said they must try to increase the workers. They must try to increase even the place again up. The offices, they are very small. It's not friendly because at some point look at what and then ba ba tseneng ka mo hare ke ba batlang ba tla ba bang successful for nako eo,
but ba ba leng ka mo ntle ba tlo ba le problem.
ka kra hore ke timeditse karata blue card ya ka hore ba ntshetse file ka tlhakanya le hore ke kry-ile e le low shading ba re bona ba re keng generator ha e bereke and then a bana diesel ba palla ko nthusa since ke fitlhile kwa ka 27 ke thusitswe ka 3:30 to 4 he clinic e elo tswalla and then ba re fa di attitude tsa hore he ke timeditse cut bona ha ona le ntho ba ka irang because of the barking the computer a di teng le ke ba fa ID ya ka ke sa kry thuso ka be ka ya go le festering ya ba hore tshwantse ke rase hore ke thusiwe ba ntlhalohanya and then ne se nna fela like ne le ntshwe ya le batho ba ko ntlo ba itse ke hore ba ba tshwara hampe wena e bila itse information ya ha wena o itse ID number ya ke ba bona ba ba fa di slankananyana like and then ya be hore ba nthusa nna ka be ke kra motho ke mo tlwaetseng hona ka mo clinicing ya be hona a thomang ho nthusa ile ba nna ntshwele ya hore o ka re ba nketsetsa favor and na ba nketsetse favor ke tlile clinicing ka hore ke nya go thusiwa batho ba ba leng around Zamile ba o jagala sengeng he ba ba tlwaetseng batho ba le ba di fine o khone o kra mo lining a tsene straight a shoot like o ka re ke motho na booking and then a ona le hore ka ngala ke clinic e leng khaufi batho ba bantsi ba mo ba tshabetse dube because of attitude ya ko Zamile ba utlwa hore ke like ish antlapela na Zamile na ibile no re tsamaela ko Dr. Ntuli hore ngwana o yele na clinicing ka mara o ile mo tlhabisa mo around o ntse 50 rand ke ntse re kopanya le wena ko Zamile ke attitude ya batho ba ka mo
Greetings. Nna ke tsamaya ko stanza 1 ke ko art.
I'm a patient on ARVs and I use stanza 1 clinic.
Nna bothata ba ka bo bogolo ka kopo Ritshidze re khopela fela re lweleng stanza 1 se di tshila. Stanza 1 se di tshila ha o no ro ka tswa ka mo clinicing ela was one infection and ho ba tlhalosetsa manese o ba botsa ka stanza ka mokhosi le nditshila ba o botsa ba re wena e le hore o phala balwetsi ba banka eng toilet di ditshila di a leaka di pompa di na metsi a di na metsi ko re hwaela ho tshwere back ha o no re tlotse back ha o e beya mo fatshe.
So in stanza 1 clinic, it's very dirty. And when you try to address it with the nurses, they ask you what makes you think you are special or important more than other patients. The way the clinic is filthy, there's water leaks everywhere, the taps are not working, and you can't even put your bag down in the floor.
Manese ako stanza ana le attitude. Especially rena ba re tsang di ARV. A ke tsore ba re tsela o eng or ba re lebelle ba re tsaka mokho ba re lebelletseng.
The nurses at Stanza Clinic have a bad attitude, especially towards people living with HIV.
And the other thing, naka kopo yaka. Ke khopela thata yona eho le taba ya dipilisi bathong ke lla ka taba dipilisi why dipilisi tsa rena hona beno ba re fa tsona so public pele dipilisi tsa rena ne ba re respecta ka tsona but now ha o sana ntweo pilisi tsa rena tshwantse di bone ke motho o mollo mong tshwantse bone hore hai ba ke ba di ARVs.
And another problem that I have that is happening recently in the clinic, they just give us our medication without any package, where everybody in the clinic can just see that we are taking ARVs. This is the case that is happening now. Previously, it was not like this.
Arithabe ka nnete arithabe a ba re tshware pila ka mo o yela di ARV ka mo ke di tsukiri ke di high blood ho tswa ka mola o tswa ba neng dilo tsa hao tse tsotlhe di le go gym o tsene furugo ka 5 o tswa o feletsa o tswa ka mo stanza ka 4 o'clock ka 4 and then le thuso ya teng o nna sebaka o sa bone doctor le ba le re ba o fa dipilisi ba o fa 3 months e tlang o tshwantse o bona doctor ho tsena ha o sa bona doctor ba no manese ba utlisetsa file ya hao ba re ya pharmacy nahana o fetse 1 year 6 months o senke o bone doctor o senke o bone doctor ebe o felletse o lwa o ba botsa gore batho ba modimo a bona this time ke khopela o bona doctor.
Another problem that is happening that they do not take us to a doctor for consulting. It happens that you can go to the facility for more than 1 year, 6 months. They will just write a prescription on your file and give you a file to say, go and collect your medication in the pharmacy. I'll had to fight with them for me to see a doctor.
And the other thing, ka di doctor tsa ko stanza, ba good,
encounter it's with the nurses.
and then le taba ya ma security tshwantse se itse mmereko wa sona ko stanza gore yena o tlile o bereka eng la nkutlwisisa. So like ho tswa mola ka mohare ha o sana condom, ha e teng condom o tshwantse o di late kae ko ma security o fa ke ma security di condom mare ka mohare go na le pleke mo di condom di ka nnang mo teng o tshwantse o kry-a kae di condom ko ntwe tshwantse bene go tswa ka gate le batho mme ba no lebelela ba no re a mara mme o le yena o irang ka di condom and le nna ke re ke motho ke na le maikutlo.
So another problem is the security guards at the clinic. They need to know their job and not do the job that is not theirs. What is happening currently in the facility, you will not find condom, and we are expected to ask condom from the facilities. And that is very embarrassing as an older woman. People will be looking to say, what is this woman going to do with condom? But I also have my sexual needs.
Ka re tlo ba betha bjano sizo ba shaya ene ba tlo re ntsha kae ko dikuranteng ya leboga.
Thank you.
Dumelang bagolo.
Greetings, everyone.
Nna ke tsamaya Tlamelong, Tlamelong Hebron Clinic.
I use Hebron Clinic
Ko Northwest.
in Northwest.
Northwest ke kliniki e nngwe pele e ne e siame go ne go na le a facilitator e leng gore sele ya tlhokofala mme Maletlape. She was so good by then. Go ne go tsamaya ga sentle ko Ibirone mara up to so far ga isele go tla di new facilitators. Ooh, Ibirone it's so filthy. Go na le di gogaiki ka mo kliniking. We are so packed up. O tsoga mo matsheng o fitlhele batho ba bookile kliniki ka 4 o'clock, where else o tshwantse o tsene ko kliniking e buluwa ka 7 o'clock. Then problem ya ka e one e ke seleng ke observer as a community member ke realize-itse gore go na le matsapa mantsi motho o sele a tlhokofala re tshela noka kana ge re ya kliniking mme ba mo fitlhetse mmogo a tsogile ka matsa e ne le mariga.
So I use Hebron Clinic, and previously the clinic used to be good with the former staff that it was working there, but now everything has changed. We are so overcrowded in the clinic. We have to wake up early around 4 a.m. to an extent that recently they find a woman that was killed in the river because from where we stay in the township, we have to cross the river to go to the clinic.
And it's a rural area. In rural area, gore inne overpacked bana yetsa ke temana ya gore ba tseya people from Itsoseng, people from Block E, people from Bangladesh, go tlhagele people from Beverly Hills. So re berekisa kliniki e one.
So clinic ya rona e mo situation e leng ko magaeng and lebaka la hore re be bantsi ko clinicing ke lebaka la hore ba nka batho from the different areas tse a dimensionileng mme.
Bianong ne ke tshepa gore Ritshidze ga le ka tsenella tlheng lebellang ditliniki tsa mo magae lona di MEC ra le kopa tswetswe gore re thuseng gore ibile re thola malwetse ka ruya overcrowded ka mo gare ga clinic.
So our plea to Ritshidze and also to the Department of Health, the MEC, is that we need some intervention in our clinics, particularly the rural clinics, because we are overcrowded and this might be also resulting to us getting more infection in the clinics. Thank you.
Ke leboga ke re yalo bona ke ba bona e le batho ba ba ntseng sentle manne sa re thusang but ga ke itse mo ba bang gore ba ba tshwara bjang rena ba HIV and AIDS ba re tshwara sentle re kry medication a rona right but ntho e leng gore gona bjanong ke e observile ba ntlositse from the pele box ke boetse back to admin so ka mo admin o tseya nako e telele you can wait for more than 5 hours and the written time on their board they say 2.5 hours as long as only chronic up to 3 hours.
So another thing that I've observed is that I've been taken back from the CCMDD program to be an in-facility patient. And in the facility, it's written that as a chronic patient, your waiting time is 2 hours to 3 hours, but that is not happening because I waited the facility for more than 5 hours. Although the nurses are friendly, they are treating us good, but we wait for too long in the clinic.
Ke leboga ke re yalo tseang molaetsa le o fetisetseng ko bagolong tle le re thuse.
I'm requesting that my message be passed to the relevant people that could assist in this regard.
Thank you.
Ke a leboga.
Thank you. The National Health Act, Section 77, talks about the establishment of the Office of the Health Standards Compliance. And then Section 78 talks about the mandate of that office is to say its duty is to enforce compliance on norms and health standards, which among other things talks about issues of infrastructure, the quality of services, and whether the patients are satisfied with the services. In South Africa, currently we've got an estimated number of about 3,800 clinics. And these clinics are inspected annually by this office. From 3,800, from where I'm seated, I can safely say in South Africa, we've got less than 500 clinics that have been issued with a certificate of compliance by that office, which means those clinics are up to standard in terms of these norms and all what have you. And the rest of them are non-compliant. And in order for a health establishment to be accredited to provide the NHI under the NHI fund, they need to have that certificate. What does that mean? It means if tomorrow we were to be told that we're going to implement the NHI, less than 400 clinics that will implement NHI. And also Section 78(9) says this board is supposed to advise the minister. I asked them in our last meeting, when or how often does this board convene meetings with the Minister of Health in order for the Minister of Health to be privy with the reports of the office? But one thing that I'm going to say here, one of the things that office, we are pushing for that office to do now is to take punitive actions against health establishments that are not compliant even after re-inspection. These clinics will be penalized now because we have realized that the issue of infrastructure, renovation of our clinics and refurbishment is not taken serious. That's why all the times whenever there is a problem within the health department, they take money which was designed for renovations and everything that has to do with infrastructure, take it and put it somewhere so that we continue to having clinics that are not in good conditions, so that we can continue to be accessing in health services in congested clinics. But also from good district management of Tshwane, a lot has been said about stanza this, stanza that. I think it is important for the district to pay critical attention on this. Provincial chairperson of TAC and other leaders who are here, it is important that you convene a meeting with the district chief director and the MEC to address these problems. We cannot have clinics that are like a pigsty. And you know what is, as people were talking, I have been reading what is written on that banner and that one. That banner is written, "We demand dignified, safe, and friendly healthcare now for the LGBTQIA plus people, sex workers, people who are using drugs. Fix our clinics." That one is written, "Our voices, our health, our rights. We demand dignity for all." That's why we are here. It's based on what is written on that banner and that one. It's all about dignity and the rights. And if we do not get the dignity and the rights, it therefore means, Comrade Monwabis and leaders who are here, something must be done. But let's engage first. Before we get angry and do other things, let's engage first so that we can get commitment and timelines. Then if commitments are made and timelines we have been agreed upon and there is nothing which is happening, it is only then that we can start thinking about rolling up our sleeves. Zilime zekin. Because from where I am, I believe too much in Che Guevara. Comrade Ernesto Che Guevara said, "I am not a liberator. People are their own liberators." No one is, there is no Jesus in this case who's gonna come from heaven to sort these problems. Each and every one of us here, we've got a role and a responsibility to fix the broken public healthcare system. We must take it upon our hands to work with the Department of Health to get rid of these wrong people, fix the system. And we can only do so when we work together. And not only work together when we are in boardroom meetings. You know, I was so worried when Dr. Aaron Motsoaledi was moved as the Minister of Health. My relationship with him was not good, but I liked it. Because wherever I was, whenever I see a problem, I will text him even if he is going to a cabinet meeting. I will text him and say, "You are not going to that meeting, Minister, until 1, 2, 3 is resolved." Anele, I am the Minister, district, and I will say, "You've got a political power. Instruct those officials to tell them that you are here." It is only our anger, comrades, our anger and our frustrations that will change the situation. But when I'm saying our anger and frustrations is what is going to resolve the problems that we have, I don't mean that we must ban clinics, we must ban streets, no. Let's leave our, you know, nurses, when they are ill-treated by their employer, they block our clinics. When we are ill-treated by nurses, let's go and occupy offices of the department. Let's go and occupy offices of district managers, MECs, and whoever, so that they can feel what we feel. David Makura knows. We went to his office without a permission, under lockdown. We slept there for 3 nights until he came to meet with us. It is only our anger, comrades, that is going to change the situation. We are the products of the struggle. We are the products of the liberation struggle and apartheid victims. So the same anger we used against the apartheid regime, we must use it against our own government in order for things to be fixed. The Department of Health should ensure that all public health facilities have a functional generator, like we have outside, with sufficient fuel and rechargeable bulbs, so that health services and administrative work can continue during load shedding. Ensure that all public healthcare users are consulted, tested, and or cancelled in private rooms. Carry out an audit of all facilities to assess infrastructural challenges. after which the department should develop a plan in order to renovate buildings and ensure adequate space to provide efficient private and safe healthcare services. The department must publish the audit results. In the interim, the department must provide temporary structures and ensure that more people living with HIV are being decanted out of the facility and receiving longer ART refills to reduce the burden of overcrowded clinics. Ensure that all facilities are maintained to the highest standard of cleanliness, including through implementing regular cleaning rotas. Ensure clinics have resources to provide soap and toilet papers in all toilets.
The next group of issues are on TB infection control. In South Africa, around 300,000 people develop tuberculosis every year, and about 56,000 people die. Yet, TB infection control in our public health facilities remain inadequate. By following a simple checklist of good practice, including key measures that were implemented during COVID-19, facilities can be made safer for public healthcare users and staff. With the checklist in mind, Ritshidze has developed a scorecard and a traffic light system to rate clinics on how good their TB infection control is. Clinics that adhere to all measures are given a green light. Those that are on the right track but still off target get a yellow light. And a red light is given to those that are way off the mark on ticking the checklist for the 6 measures. In July and August 2023, no facilities were awarded green status for checking all 6 measures on the scorecard. 5 facilities were awarded yellow status for following about half of the best practices of measures for infection control. This leaves 24 facilities surveyed that failed altogether to meet these 6 best practices to stop the spread of TB. We now move to recorded stories, to community stories.
We're shooting straight to recommendations. We do not have recorded stories or person in the house. Colleagues, all of us now, we have a serious problem in South Africa. According to the World Health Organization, it is telling us that about 56,000 people are dying of tuberculosis in South Africa every year. Out of that 56,000, 33,000 of those people are people living with HIV. It therefore means we cannot separate our response to HIV from TB. TB is a day, 153 people are dying of TB. Yesterday, 153 people died of TB. Even today, even tomorrow. That's what is happening. And our government took COVID as a priority more than TB and HIV. TB is curable, and the available TB drugs, which are effective, are expensive for poor people to be able to access them. That's why we are fighting against Johnson & Johnson for monopolizing the patent laws and make profit out of the lives of the poor people. That's why we are calling upon the Department of Trade and Industry to speed up the process of enacting the country's intellectual property rights and patent laws policy, so that as the poor people, we know what we fight for. It has a backup. Look at the COVID. COVID came 2020. Chiki, there are vaccines. You know why? Because COVID didn't ask the class or the race. It affected the rich, the poor, the middle class, everyone. That's why the capitalists of this world were able to speed up the process of coming up with vaccines. Let's look at TB. TB is older than all of us here. But because it affects poor people who cannot afford these expensive prices of medicines, That's why they don't care about TB. You go to India, you go to Brazil, you go to China, you go to everywhere. The majority of the people, even in South Africa, the majority of the people who die of TB are poor people. Until such time, we as poor people, we stand up and fight for our rights. We will not be fighting for ourselves only, but we will be fighting for the generations to come after us. If we do not force the pharmaceutical companies to reduce the prices of TB medication, majority of us are going to die. Something must be done. We need to fight. If we were able to force pharmaceutical companies to reduce the prices of ARVs, we can do the same on the TB drugs in order for us to make sure that we reduce this number of more than 153 people who are dying on daily basis because of TB, XDR and MDR TB. The recommendations are as follows so far. The Department of Health should issue communication to all facilities stating that all windows must be kept open. TB infection control posters must be displayed in visible places in the waiting area. Public health care users must be screened for TB symptoms upon arrival. People coughing or with TB symptoms must be seen first to reduce the risk of transmission. People coughing or with TB symptoms must be provided with masks. People who are coughing must be separated from those who are not while waiting. Carry out a full audit of all public health facilities in the province to assess TB infection control based upon World Health Organization guidelines, after which the department should develop a plan based upon the infrastructural, human resource, or behavioral challenges found. In order to improve the TB infection control, the TB must publish the audit results. We have come to an end of our report. This report is very long because it's a written report, testimonials that are recorded, and testimonies that are given by people here. So now we moving towards the end. And I'm told there at the back that we've got less than 20 minutes before everything switches off. So we need to speed up. So I will call upon a leader from Napwa, uComrade uThozama Komana, ukhona? Going once, going twice, akekho. Then we will call for TAC, sibize uComrade Amukelane Baloyi. You've got 2 minutes, Comrade Baloyi. Okay, when you will take over, you are a leader now. Okay.
Nyanbingelela. So ngale 20 minutes abasiphe yona uphe mina. 2 minutes. Oh. Okay. So I think I won't repeat what has been spoken, but we have heard all the challenges that we are facing in Kliniki, and as TAC will make sure that we get really deep with these issues. We will make sure Pretoria and Tshwane becomes a proper place, and our facilities are corner. They are friendly users to everyone. And in that regard, we'll also request to be invited to meetings where Putuma has the NNF Center meetings, so that we can be part of them every time when we have them, so that we can also bring whatever that we have to bring to make health care, say Tshwane, to be the best. Thank you.
Thank you, Ngokeli. You are raising a very important issue here of a participation on Operation Putuma meetings at provincial and district level. Mina and that comrade outside, we sit at national in Operation Putuma meetings. And that's where we are banging tables, Kwabo Romi and all of them, and tell them what needs to happen. But also, we are able to produce data and evidence on what is happening. And that affords them an opportunity to have that perspective of a community in order for them to bring about the change. And it will be good in Gauteng that as Ritshidze, TAC and the PHIV sector, to be part of the Operation Putuma meetings at provincial and at district level. Now I will call upon Yvette's RHI to come and say few things, And then the rest of the time I will give it to the Department of Health. You've got 2.5 minutes. 3 minutes.
Thank you so much, Chairperson. And because I have 2 minutes, I think I'm not going to cover all that I've prepared. So I'm Stina Mujela, Senior Program Manager for PHC. And as Ritshidze, we really acknowledge the report and appreciate the work that was done by Ritshidze. And we are really prepared to work together with the Department of Health and City of Tshwane in ensuring that we give quality of care to our patients. And as Ritshidze, because somebody will be asking, where's the DSP when all patients are complaining within our facilities? So we do have staff members that we have seconded to the department in terms of support, nurses, counselors. They may not be that much, but we have, according to the needs, we have allocated treatment navigators, case managers in order to support the patients, PSS counselors. But because we are funded, we may not have a lot, but we are working together in ensuring where there is a gap, we really close those gaps. And I think one of the things that came was CCMDD, where patients need to be decanted. We are working together with the department, and we also assist them in identifying patients that are eligible so that they can be decanted, so that the facilities can be decongested. And we have 11 pillar boxes that we were able to support the department with. We also have more than 150 external pickup points that we were also able to assist the department in also identifying. And currently we have started with we saw that their adherence labs are a real need. So, but now we concentrated on 4 priority facilities of Putuma, of the 100 ones, which is Stanza, KT, Mutubazi, Khabo, and Lodium. So we have started there because we saw that there is a need, and we have also appointed the CBOs that will assist in this regard. And in terms of capacity building, which is one of the things that was requested, we have also trained together with the department on the new guideline, non-clinician and clinician, so that we make sure that our patients receive a quality of care. And there are other activities where we also like to find out what are the challenges that patients are facing, especially when they are disengaging. We do file audits, and we also report to the facility what are our findings. And in terms of infrastructure, I think the facility that has been talked about, Stanza CHC, one of the infrastructure, temporary one, is of the DC. We have hired that for them so that they can be enough space for data capturers to also work. There's a lot maybe, but I think with other meetings, Ritshidze will have a better understanding of how Ritshidze is supporting the district. But we have seen the recommendations. We'll work together with the department and make sure that we cover all the concerns. Thanks.
Siyabonga mama. Siyabonga vets RHI. Now, I do not know how does the protocol of the department works, but now, department, you've got 15 minutes. It's up to you how to use it. But I do not know who to give the department. And I have a dokotela, Mr. Makud, Tlakopili in that. I address the issue. Missed. Umoya uchoka mandi ke ngapha tata.
Ke a leboga Moradisi. Dumelang bagaetsho. Nna ke Modise Makhudu, ke tshwere role e tshwanang le auso qetang ho feta for primary health care. Firstly, ke kopa ho leboga the organizers, and just to acknowledge GS that we have met le Bokagiso, and we had what we call a preliminary report. And testimony telling more today di utlwisa botlhoko. And I hope the managers ba utlweletse and will take it up with them le bo Kagiso, to acknowledge the inputs tse le tlo di etsang. Thanks. No, operational. What we should do operational.
Dumelang bagolo gape ka mo tenteng. Just a reminder from the program, yeah, Haste. Yes, we had the testimonies from our clients, our patients. I think what we can do is to make a commitment that we need to work closely together with Ritshidze on improving all these services that are around HIV, STI, and TB. Since we started working with Ritshidze, I'm not sure from engaging like closely from last year, I think the services has improved a bit because there are areas, there are facilities that have improved from a certain percentage in terms of different services that are being explained, or infrastructure, or services like I said. So what we need to do is just to continue with this engagement closely together with Ritshidze. Yes, we have trained colleagues from Ritshidze on Operation Potoma. We just need to train more colleagues from Ritshidze. We started engaging, I'm not sure if it's provincial people from THC on working together on Operation Potoma, but it looks like that communication just broke somehow, I don't know how, but we'll revive that communication together with TAC. And yeah, from facilities, I think we just need to work closely with the PHC managers as a program, just to attend the HIV, STI, TB services in our facilities. They are affecting our performance. I'm not sure if Ritshidze it's having the report, Dr. Madonzela, around the APP indicators performance. That performance is not of a good standard. It's a dashboard which is indicating red colors in most of the indicators. And when I analyzed the situation from these reports that we're getting from the clients and the patients of our facilities, that performance it's being contributed or affected by all these services in our services, so our facilities. So if we can improve services in our facilities, I think we can improve as well as on our APP indicators. Thank you, Jay.
Okay. I thought because the manager has spoken that he has covered everything. No, we acknowledge Ritshidze for the report. You know, some of the issues, we know that we had the report last year, and we thought we had improved, especially with the key populations, because we have opened the Center of Excellence in town, and you were part of it. But we see that we still have a lot of work to do in training our staff. And we also have heard about the condom availability and not putting them in the security. We have condom containers. The program manager had purchased condom containers. So I think we will work with the district. We really appreciate the feedback that is coming from the community and our patient, the way we will do better. We are hoping that as we work collaboratively, we will be visiting the facilities like Bostanza and try to make sure that we give you a better service. As the program director has said, constitutionally we are bound to provide those services to our patients. So thank you very much. We have heard you, Babe. We will include you. I think maybe it was left behind as the stakeholders we engage for our Operation Putuma. We will include Ritshidze in the provincial Operation Putuma and request that it is also done at the district level. Thank you.
Mandla, Mandla, Amandla, 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 all power, all power. I was in KZN last week with the national organizer, having meetings like this with the comrades. The provincial manager of TAC in KZN made a declaration that 2024 is the year of the people's power. For Operation Putuma, ma'am, you've got this comrade who is wearing a black cap with a red star. His name is Monwabisi. He is the provincial chairperson of TAC. Ukhona omnye comrade olapha ongTshepo. Tshepo Mabuwe, he is the provincial manager of TAC in Gauteng. No Sisi Lobe translator, Upelinda. Those are the relevant people for both TAC and Ritshidze to reach out to in terms of the Operation Putuma meetings. Also, Mantatel Tuba, Dibonga Gumdu Wongo lapha endlini. We were given an opportunity, we were listened to, and the officials have listened, with the hope that when we convene a meeting like this again, we will be having a different report where we will be reflecting on the improvements and how things are working better for us. Siyavala ngoku besivulile khange sivule ngamthandazo khange sivule ngacula. Savela savula nje because besingxamile kuyachisa. Siyavala ngoku, but I'm told that kukhona ukutya and the people must sit down. I'm not sure whether I'm right or wrong. Ikhona enye ingoma andikwazi ucula ke mna ke. Ikhona enye ingoma ethi kancane sekusele kancane kancane sizophumelela kancane sekusele kancane kancane sizophumelela kancane sekusele kancane kancane sizophumelela eGauteng sekusele kancane eTshwane sizophumelela eGauteng sekusele kancane kuruleni sizophumelela kancane sekusele kancane kancane sizophumelela Eastern Cape sekusele kancane eLimpopo sizophumelela Mpumalanga sekusele kancane eNatala sizophumelela kancane sekusele kancane kancane sizophumelela Mandla 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 Manga Manga. So comrades, that was the only way to thank you all equally for a very productive and fruitful meeting, with the hope that sizawusebenzisana and change the situation on the ground. The meeting is adjourned. uThixo anisekelele nonke anikhaphe xa nifike emakhaya umoya engcwele ube kunye nani.